live.
Good morning, dear students and all the viewers of this Super Sunday from Cochin Ophthalmic Club. Yet another edition of Super Sunday, which we have been having for more than a year now. And this is a very unique Super Sunday because this is something, which all of you are going to experience at some point of time in your career. This is just like an exam, but we are not going to, examine you or, trouble you too much. Very nice format for examining, but I'm sure this is going to be very, very useful, not only for the students who are in the doing the exam, but for all the students who are watching. This is going to be a great experience, and even for us seniors, I think for in all subspecialties, it's going to be a great experience. It's my proud privilege to welcome Dr. Vanati from the RP Center and Dr. Nagaraju from RIO Minto, Bangalore. Thank you so much for sparing half a Sunday for our sake. We are indeed, very, very thankful for your presence today. The whole program is like in every month. It's the brainchild of Dr. Gopal, and so he will briefly take you through what we are exactly going to do through this program. Towards the end, we also will have a short talk on glaucoma, because the World Glaucoma Week is starting today. And so a very short talk by Dr. Thomas Arun Varghese, one of the senior glaucoma consultants in Cochin. And I also thank Allergan for supporting this PG initiative. So with these few words of introduction, I request Dr. Gopal to take over, introduce the faculty, and get ahead with the program.
Thank you very much, Dr. Sai. I think you have basically set the ball rolling. Now, this is a program which is intended to be a survival kit for the postgraduate long case examination. And the gist here is not for testing the knowledge of people, but the technique of answering and how you should be going, and constructive criticisms at the end of the day. So the format that we will be taking is that we will have 5 minutes of case presentations. And after that 5 minutes of case presentation, there will be about 20 minutes of viva. And then final 5 minutes, that is half an hour per candidate. The final 5 minutes will be for constructive criticisms onto the technique of answering. Because these examiners, one is Dr. Vanati, Professor of Cornea and Refractive Surgery at RP Center, All India Institute of Medical Sciences, Delhi. So she has written that book on postgraduate ophthalmology, which I'm sure most of the postgraduates are reading. It's a wonderful book, and that shows her commitment towards teaching. She and Dr. Zia had co-authored this particular book. Dr. Nagaraju is a senior professor at the Regional Institute of Ophthalmology, Minto, Bangalore, with more than 30 years of experience. So he's a wonderful teacher and examiner. So without wasting any much more time, we will go into the exam. We will have half an hour per candidate. This, I'm sure, will benefit a lot of postgraduates who are, in fact, going to write the exam in the future. Over to you. Who is the first case presenter?
Dr. Pravina.
Yeah, Pravina, you can press. You can share your screen.
Good morning, respected sir and madams. Today I'll be present hailing from Movatupura, who is a tailor by profession. And she presented to our clinic with complaints of decrease of vision in both eyes for the last 3 years, with intermittent left-sided eye pain and headache for the last 2 years. My patient was apparently normal 1 year back when she developed gradual onset painless progressive decrease of vision in both eyes. She initially ignored it, but over the next 10 months, her symptoms gradually worsened such that she had difficulty in reading newspaper or doing stitching with her present glasses. She also experienced recurrent left-sided headache and eye pain during extended hours of work and while watching television at night, with difficulty in reading news scrolls from her normal viewing distance, with colored halos which got relieved on taking rest. But she did not have much difficulty in reading bus boards or hoardings or identifying people in the same room. There is no history of any redness, diplopia, or associated nausea, vomiting, photophobia, seizures, or trauma. There was no significant past ocular history. She is a known diabetic for the last 7 years and had systemic hypertension for the last 3 years, but not on regular medications. Her diabetic status is well controlled with oral hypoglycemic agents. Her personal history is normal, and she has a sister who had history of glaucoma and underwent surgical treatment for the same. Coming to examination, general examination was normal. Patient was moderately built and nourished, conscious, oriented in time, place, and person, and cooperative for examination with normal vitals. Systemic examination, including cardiovascular, central nervous system, and respiratory system, was normal. In ocular examination, head posture was normal with the ocular alignment orthotropic on Hirschberg's test with no facial asymmetry. Extraocular movements, versions, vergence, and ductions were normal. Unaided distance vision was 612, improving to 6.6 plots with pinhole in the right eye, and in the left eye it was 624, improving to 612. Color vision was normal in both eyes, and visual fields by confrontation test was normal in both eyes. Objective and subjective refraction was done, and with subjective refraction she was improving to 6.6 blurred in the right eye and 6.12 in the left eye, with the near vision improving to N6 blurred in the right eye and N8 in the left eye with plus 2.75 sphere. Anterior segment examination. First, right eye. In the right eye, except for a shallow AC of Van Herrick's grade 1 and lens, cataractus changes in the lens, all the findings were normal. Whereas in the left eye, cornea showed pigments on the corneal endothelium and a shallow anterior chamber with a Van Herrick's grade 1 and faint flare, with loss of pupillary rough from 5 to 6 o'clock position, and pupils were 4 mm round with a sluggish direct reflex. And
I think we just lost her.
sorry, sir.
Yeah. Okay. You were having a little bit of internet problem in between. That is okay. Yeah.
Goldman applanation tonometry at 2:30 p.m. was right eye 26 millimeters of mercury and left eye 33 millimeters of mercury. Gonioscopy was done in the right eye, which on manipulation showed a Schaffer's grade 0 superiorly, grade 3 inferiorly, and grade 1 nasally and temporally, with normal pigmentation, no evidence of neovascularization and convex iris configuration. On indentation, there was evidence of multiple focal pass superiorly with a focal pass nasally and temporally. In left eye gonioscopy, on manipulation was showing Schaffer's grade 0 superiorly and nasally, and grade 1 inferiorly and temporally, with hyperpigmented trabecular meshwork and no neovascularizations and convex iris configuration. And on indentation, there was diffuse pass superiorly and multiple focal pass nasally and focal pass temporally. Fundus examination under slit lamp examination with 90-day lens was done. In the right eye, media was clear and the optic disc was normal in size and shape. It was vertically oval with alpha and beta atrophy from 6 o'clock to 12 o'clock position. The cup disc ratio was around 0.6 into 0.6 with a lamina dot sign near the superior rim, with superior focal thinning at 11 o'clock, with peripapillary wedge-shaped RNFL defect and splinter hemorrhage along the supratemporal disc margin, and vessels over the disc appeared normal. In the left eye, the media was clear. Media was slightly hazy due to cataract, and the optic disc was vertically elongated disc with alpha and beta atrophy from 6 o'clock to 12 o'clock position, with a cup disc ratio of 0.8 to 0.8, with a supratemporal NRR loss from 12 to 2 o'clock position, with a large area of wedge-shaped superior peripapillary RNFL defect, a deep cup with a laminar dot sign, and a focal neuroretinal rim loss inferiorly at 6 o'clock position, with bearing of circumlinear vessels and a wedge-shaped inferior peripapillary RNFL defect. This is a disc diagram. And the macula was also normal. Since the angles were closed, we did not dilate the patient, so I couldn't assess the diabetic status of the patient. The summary is 60-year-old female who's a known case of type 2 diabetes mellitus and systemic hypertension with family history of glaucoma, presented with gradual onset, painless, progressive decrease of vision in both eyes for the last 3 years, associated with intermittent left-sided headache and eye pain for the last 2 years. Best corrected visual acuity in right eye was 6.6 parts and left eye 6.12, with a near vision of N6 blurred and N8 with 2.75 sphere. And both eyes, the anterior chamber was shallow, with left eye showing pigments in the corneal endothelium and loss of pupillary ruff. And both eyes showed a high IOP of 26 and 33 millimeters of mercury, with closed angles with more than 180 degree of iridotrabecular contact, and glaucomatous optic disc changes bilaterally, more in the left eye. My provisional diagnosis is both eyes primary angle closure glaucoma, with both eyes compound hypermetropic against the rule astigmatism, both eyes immature senile cataract, with type 2 diabetes mellitus and systemic hypertension.
You can stop your screen sharing. You took 8 minutes for presentation. Yeah. Over to the examiners.
Dr. Praveena, excellent presentation. Am I audible?
Yes, sir. Yes, sir.
Yes, sir. You are audible.
Coming to the history,
Yes, sir.
whatever history you have presented, you should have described it in much more details actually. Whatever history you have described, especially the decrease in the vision, that it has to be very, very elaborate. You have just made it a sort of fragmented presentation. Hello?
Yes, sir.
That you have to describe more clearly actually. That is one thing which I would like to tell you. From the history itself, what are all the differential diagnoses? See, the patient, whatever history you gave, was a decrease in vision in both the eyes for the past 3 years in a 60-year-old female with intermittent left-sided pain and headache for the past 2 years. And some of the points, whatever you have put in the presentation, in the history of presenting complaints, you have put some words in her head and you have just taken the history like that. Basically, whatever you described in the history of presentation, you should describe as though it is the patient describing the complaints in their own words actually. Those rainbow halos and all those things, you should be more descriptive in whatever they tell, rather than just telling rainbow halos and all those things, okay? That colored halos and all those things. You should tell that around the light, they were not able to see any colored rings or something like that, okay?
Yes, sir.
Hello, yeah. And one more thing I would like you to tell is you can add one point in the history, taking as an optical history also, optical history, that you have to mention as in a separate heading. You have made all the other things clearly, but optical history is also very important in any ophthalmic case presentation, especially if it is a long case. And this can be kept as a short case also, but long case, you should tell the optical history. So coming to the from the history itself, from the complaints the patient is having, what are all the differential diagnoses? Decrease in vision in both the eyes. See, basically, you should have in mind some diagnosis when you present a case. From the history itself, you should come to some conclusion. Then you should start examining, because we have not seen the patient directly. Yeah, tell me.
So the patient is having a gradual onset painless decrease of vision for 3 years. So it could be a cataract for the patient. It could be the development of cataract.
You should be more specific. You should tell it is a senile cataract. Don't tell cataract. You should tell, be more specific in your answers. Yeah,
Yes.
tell me.
It could be a senile cataract. Then the patient was having intermittent headaches in and eye pain, especially at the night time. So that could point towards
one second. Decrease in vision, it is a chronic gradual diminution of vision. You should keep in mind what are all the causes of chronic gradual diminution of vision in that particular age group, 60-year-old female. Okay, so you have told only two. You told one is senile cataract. Second
is glaucoma, sir.
What type of glaucoma? Be very specific.
Primary
gradual diminution of vision. That is only the first presentation, whatever you are telling. No, you should think of chronic simple glaucoma also. Yes. Okay, then what are the other causes which can occur bilaterally in an elderly person?
Sir, it could be
anything in the retina which occurs both sides, causing gradual diminution of vision.
Age-related macular degeneration.
Any other diseases in the systemic conditions which can affect the retina and produce gradual diminution of vision in both the eyes?
If the patient is diabetic, then diabetic.
Yeah, all those things you should keep in mind. That is from your first presentation. Second is, you told intermittent left-sided pain and headache only for the past 2 years. Yes. So probably at the age of 58, she developed this complaints. Okay, yes. She's 60 now. Yeah, tell me.
It could be an ocular migraine for the patient, sir, since it is unilateral.
Systemically, what condition the patient is having? Diabetes, hypertension?
And hypertension is there.
She's having hypertension.
Hypertension and diabetes.
Yeah, then what other things?
Sir, it could be a migraine attack for the patient, or it could be an
migraine. Is this the age you should think of migraine at this age? Of course, it can occur, but this age only for the past 2 years, very unlikely. Next.
Then acute glaucoma attacks for the patient.
Other than glaucoma, you think of other things.
Sir, it could be an arteriolar occlusions like the uveitis for the patient, anterior uveitis for the patient.
Now, from whatever presentation, whatever positive findings you have given in your case history, from that you pick out some things. From the refraction part, I think patient has got hypermetropia, no? Hypermetropia, find out whether she was wearing glasses continuously or not. Hypermetropia also can produce a lot of asthenia and headache and other things. That is another thing. What is her occupation?
Tailor, sir. There is more of tailor work.
Okay. So that is another thing which causes pain. Next, you can think of other causes. Yeah, tell me.
Sir, it could be because the patient is hypertensive, it could be an ischemic optic neuropathy for the patient.
Ischemic optic neuropathy will produce pain?
Anterior ischemic optic neuropathy.
No. Extended hours of work, pain and all those things. One is your hypermetropia, that can explain all those things. Second is your systemic hypertension, can also explain all those headache and other things. Third is a chronic condition like this, gradual diminution of vision for a couple of years, 1 or 2 years, and suddenly the patient will start developing pain in one eye. What do you think? You have not examined the patient. From the first cause only you try to derive some this thing. You can think of a lens-induced glaucoma also. Lens-induced glaucoma also you can think of. Then you can come to the other condition, that is your glaucoma part. Chronic simple glaucoma, does it produce this thing, pain?
Sir, usually it doesn't cause unless their patient experiences an acute angle closure attack.
No. Chronic simple glaucoma. I'm talking about open angle glaucoma. See, chronic gradual diminution of vision. That is your second one in the differential diagnosis. What all things? How can a chronic simple glaucoma patient manifest with pain? Long-standing, uncorrected, gradual diminution of vision patient is having, and over a period of time, patient is normal, and probably a couple of weeks later, just she'll present with mild pain, like whatever complaint you told. Patient is going in for an absolute glaucoma also, can in the end stage patient can come with pain. Okay, then tell me, there are other conditions on the cornea which can also produce gradual diminution of vision, and sometimes they can also manifest with pain. What are those conditions? Pain, discomfort.
The corneal epithelial dystrophy.
Dystrophy we get at this age group. Bilateral corneal condition in this age group, what do you get? What is the commonest type of corneal degeneration you can get? Spheroidal degeneration. All those things you can think of. Sometimes they can also present with little bit of pain. So these are all the things which should come into your mind when you think. See, you know the diagnosis. That is why you have asked all these leading questions like watching television, pain, discomfort, and colored halos, and all those things. The patient usually they themselves will tell. Okay, next. You told a lot of differential this thing, negative history, no history of redness.
Yes, sir.
Why did you ask for no history of redness? Supposing the patient has gradual diminution of vision with pain in the past 2 weeks with redness, what were the things you wanted to rule out?
So uveitis for the patient, or a recent acute attack of glaucoma for the patient, a congestive glaucoma. Then a recent decrease of vision.
See, whatever we discussed just now, from those you just try to derive those causes which can produce redness. Then you can just interpolate into that. Why did you ask for history of diplopia? Patient with gradual diminution of vision, both eyes. Why did you ask for the history of diplopia?
Patient is having a unilateral headache also. So it could be a cause in intracranial space occupying lesion can also cause a headache for the patient. So I want to rule out any evidence of
that is not that much this thing. Of course, you can get diplopia, polyopia in senile cataracts, but that you don't have to ask guys actually. Then why did you ask for history of associated nausea, vomiting, and photophobia?
So that is to rule out often migraine-related headaches or raised.
Migraine, this age group is very unlikely, ma. Next, lens-induced glaucoma I can think of from the history. Next, why did you ask for history of seizures?
A seizure is also same thing because the patient is having headaches in between.
Then you should ask for history of any other neurological deficits that you should have asked. When you asked, I think that is also not relevant in your thing. Next, history of trauma.
Yes, sir. Trauma. There could be a traumatic cataract could have been a cause for decrease. Then it could be. Then it could be a traumatic ankle recession, which can cause glaucomatous changes in the patient and pain and decrease of vision. Then a traumatic lens subluxations can cause decrease of vision.
Okay, from the past history, you have come out with some systemic diseases like diabetes and hypertension in this case, in your case. Why did you ask for history of bronchial asthma, ischemic heart disease? Why is it relevant?
Sir, since I examined the patient.
No, a patient with gradual diminution of vision, okay, both eyes, bronchial asthma, can you think of any correlation?
It's a gradual decrease of vision. One of the causes is glaucoma, and if the patient turns out to be glaucomatous, and if I have to consider treatment of glaucoma,
just list the causes. Second cause, second. Supposing the patient is having some systemic medications like steroids for asthma, that can also produce your cataract, gradual diminution of vision. That is one part of it. Second is management. There are certain drugs which are contraindicated that you should keep in mind. That is your bronchial asthma, ischemic heart disease, and all those things. Okay, drug history. Okay. So optical history, I think you should add to this. Manati madam, can you just take over? You
Can I?
Yes,
okay. Praveena, is it? Yeah. Nicely presented, Praveena. But as Dr. Nagaraju was trying to highlight, he was trying to help you learn how you would use every step of your examination to lead you to the diagnosis. That is the main thing which we would like to know. Of course, we know you have not seen the patient in person now, so it's more of a virtual history which you are probably presenting, or I don't know if it's one of your clinical cases. But what you should learn from this is that as you are examining the patient, your questions should be sort of leading you, or the answers the patient is giving to you. At the back of your mind, you will form your differentials. Okay, if it is painless gradual loss of vision in a 60-year-old woman, what are going to be the differentials for this? And so your next question will be such that you will place, or you will be able to pick out a diagnosis from these differentials which you have placed in your mind. So that's what he was trying to reiterate to you right now. And again, of course, we know that now you are presenting a case of primary angle closure glaucoma. So you probably are tailoring your history to what you are having, you're ending up as your diagnosis. Several times, the candidates try to go back retro to their history and do retrospectively inspect your history. And when you're presenting, present the features in history which are going to support your diagnosis. Don't do it that way. Do it in a way like you did a prospective history taking, because when you start a case, you really do not know what the case is particularly about. So it's nice to start presenting that way and lead on to lead your way of presentation such that it is sort of picking out and saying, okay, she had all this, so it's going to be this way, rather than making it, like you've gone retrospective and then put it on. And again, don't put in points which are can always avoid putting in a lot of negative history, which is not perhaps pertaining to the case. And as sir rightly pointed out, if you have written down something, you should always prepare yourself in your mind that if I'm asked why I've said this, I should know, and I should know to defend myself. One thing I always tell my students is, please always remember that the ball is in your court. Okay, so no examiner comes prepared beforehand thinking, okay, I'm going to ask these questions to the candidate. So whatever you're going to say is going to lead us to ask the questions. So when you are holding the ball in your court, please lead us to ask good questions, or questions which you would be able to answer. That is turning the entire examiner-examinee interaction in your favor, and you hold it entirely in your hands. So don't say things which you would yourself make yourself, sort of put yourself into a sort of a knot. So that's the sort of bottom hand. I think, Gopal, you said 15 minutes for each case, or 15 minutes?
Yeah, but I think
yeah.
you have both taken constructive criticism of 5 minutes into the 15 minutes. Maybe we could ask a few questions.
Okay, so I'll just ask her, just for the benefit of making it look like an exam. Would you like to elaborate so that you would feel very confident in answering, and I'm sure you'll be shooting out your answers. So would you like to say how would you assess a shallow anterior chamber on clinical examination? Let's ask just a few questions pertaining to your case only. Yes.
Clinical examination by you can use a torchlight examination to assess the anterior chamber, which is the eclipse method, where you will shine the torch from the temporal aspect of the eye, and you look for the casting of the iris shadow on the nasal iris, and you assess the depth of the anterior chamber based on that. Then a qualitative method of evaluation can be done under a slit lamp examination, which is called the Van Herrick's method of anterior chamber depth assessment, where the slit beam is made into an optical section with maximum length, and it is shown from the it is more focused on the temporal or the nasal limbal area, and you compare the corneal thickness with the distance between the posterior surface of the cornea and the front surface of the iris, which corresponds to the anterior chamber depth. And if the anterior chamber depth is equal to the corneal thickness, it is considered to be open. That is 1:1 ratio or more than 1:1 ratio. It is open. Grade 4 Van Herrick's. And grade 3 Van Herrick's is when the anterior chamber depth is either between 1/4 or half of the corneal thickness. And grade 2 is when the anterior chamber depth is 1/4 of the corneal thickness. And grade 1 when the anterior chamber depth is less than 1/4 of the corneal thickness. If it is less than 1/4 of the corneal thickness, it is it is likely to be a closed angle. So we need to do a gonioscopic examination. Whereas 3 and 4, 4 is unlikely to get occluded, and whereas 3, it can get occluded, but chance is less. And 2 also warrants a gonioscopic examination.
Okay, good, very good. So since I think your case had an associated senile cataract as well, so it was a case of bilateral primary angle closure glaucoma with a senile cataract, right? And what patient was a hypertensive and diabetic here. So when would you decide you would like to do a combined procedure for this patient, or you would like to do only a cataract surgery procedure, or you would like to do a trabeculectomy? So basically, how would you go about making a treatment plan for your patient? Assuming the cataract is significant.
Yes. If the cataract is significant and the cataract is a cause for a pupillary block, if it is a reason for glaucoma, as in case of a Morganian cataract, it can cause a phaco.
Let's talk about your case, Praveena. So did you have a Morganian cataract? Did you have a lens-induced cataract in your case?
No, ma'am.
No, we didn't. So we are not talking about assumptions here. So we moved out from the history part. We are now just trying to discuss your case. So this was a case of bilateral primary angle closures with a senile cataract, say grade 2 nuclear sclerosis. I didn't see your grading. I don't remember seeing your grading. So let's assume it was a grade 2 or a grade 3 nuclear sclerosis here. And the patient is now sitting in your clinic and is asking you what is to be done next for her. So what would you advise, and how would you place your advice? How would you justify the advice you give her?
Ma'am, since a removal of a lens can actually deepen the AAC, and the patient has a significant decrease of vision, both distance and near, in her left eye, removal of a cataractous lens can be justified in this patient, along with the treatment of a glaucoma, where we need to bring the pressures under control. And since the gonioscopy is showing around more than 270 degrees of synachial closures, you can go ahead. We will have to plan for a trabeculectomy, which can be coupled with an IOL in cataract extraction and an IOL implantation.
Okay. So you would base upon, one is you would like to look at your lens thickness. So your lens thickness is going to say if it's a real intumescent lens, which is adding on to the shallow anterior chamber component, which is already compounded by her primary angle closure, then you would justify, and the cataract is significant enough for you to do a surgery. You would probably offer a combined procedure. Again, you know the success rates of a combined procedure vis-a-vis separate procedure, sequential procedures as well here. But your first aim of management would be to control your pressures medically for this patient, yes. And if a patient is medically well controlled, then probably you will observe and just plan a simple cataract surgery for her and see how much of pressure drop is going to come on in this particular patient, I think. So there are multiple options depending on how the patient is going to be responding. Gopal, you want us to go ahead to the next, or we can...
Madam, if I can interrupt, one more question. Actually,
yes.
in your case, Dr. Praveena, I think, I guess, you should have added a visual field report, an Humphrey report also with this case. I think the best corrected acuity was around 6.9 in the right eye, 6.12 in the left eye, right?
Yes.
I think a visual field examination report should have accompanied this, and probably an Humphrey report. And when you make a diagnosis, you have made a diagnosis of primary open angle glaucoma. To make it as a open angle glaucoma, you should document that there is a field defect there to say this just by looking. Of course,
It's a primary angle closure
It's an angle
glaucoma.
closure.
I think she told primary angle closure glaucoma.
Angle closure with compound hypometropy.
Glaucoma means you should probably document that there is a visual field defect.
Yes.
That is in my opinion. And you try to get a visual field report, Humphrey report attached to this case presentation. I think every postgraduate should know how to interpret a visual field report. That is one question which almost most of the examiners will ask. And there is a wonderful article in IJO. You just, I think a couple of years back, 10, 15 years back, an article has been published in IJO. You just goes through that, you'll get very good information on how to present a visual field report. How do you set the target intraocular pressure?
Now it's about 30 minutes.
Target intraocular pressure in this case? If you are doing a combined surgery, see, patient is 60 years, patient is having bilateral cataract, bilateral open angle closure glaucoma. Patient has got a cup disc ratio of around 0.8 or something in the left eye. This thing, you are planning to do surgery in the left eye. Last question, what all precautions you take during surgery? That is also very important. You should keep in mind to avoid a whiteout, blackout, and all those things. You should know. And how do you set the intraocular pressure, the target intraocular pressure?
Sir, since the patient is having significant cupping as well as the visual field, I didn't put the HFA chart. The HFA chart was having significant field effects. So it is a moderate glaucomatous changes are there. So my aim will be to keep the target pressure between the low teens and the middle teens. In between the low teens and middle teens, so that further progression of the disease and further cupping and changes doesn't occur for the patient.
Like Madam said, you do just a regular plain cataract extraction in this case. Follow up the patient, check the intraocular pressure. Then if you want, you can add medications. And later on, if you want, you can do a sequential glaucoma surgery. Okay, thank you.
Thank you very much for the opening case, Praveena. And thank you for your expert comments about Dr. Vanati and Dr. Nagaraju. Let us go to the next case. Dr. Maya, can you come in and present your screen? Please keep your video on as well. Thank you.
You can open your PowerPoint, Dr. Maya. Click on that PowerPoint icon.
Left side down, yeah.
Yeah. Click on that. Yeah, and then start presenting. Yeah. Full screen.
Make it full screen. Come on to the PowerPoint once again. Somehow your full screen is also, yeah, that's a PowerPoint. A full screen, making full screen from the right side bottom, you can make the full screen. Right side bottom. Yeah, there, correct. Thank you.
Am I audible, sir?
Yes, you are.
Yes. Good morning, everyone. Today I'm going to present a case of a 67-year-old male patient who is coming from Naitod. He's a farmer. The presenting complaints: defective vision in the left eye for the past 1 week. History of presenting illness: the patient had complaints of defective vision in the left eye for the past 8 months, and which was sudden in onset, for which he consulted a nearby clinic from where he was advised for detailed evaluation from a higher center, but he didn't go. Now he complains of worsening of the vision in the left eye for the past 1 week. No complaints of redness, pain, discharge, watering, photophobia, or headache. No complaints of glare, colored halos, or diplopia. No complaints of distorted vision, flashes, or floaters. No history of trauma to the eye. No history of frequent changes of glasses. Past medical history, he is a non-diabetic and hypertensive, and he is on treatment for the past 10 to 12 years, and there is no history of dyslipidemia, coronary artery disease, stroke, or bronchial asthma. He is on oral hypoglycemic agents and insulin, and also he is on treatment for hypertension. No history of any drug allergy. Personal history, sleep and appetite is normal. Bowel and bladder habits normal. He has a mixed diet, and there is no history of any addictions. Family history, no relevant history of ocular illness in the family. And on general examination, the patient is conscious and oriented, moderately built and well nourished, no pallor, icterus, sinuses clubbing, generalized lymphadenopathy or pedal edema. The vitals, pulse rate was 74 per minute, regular in rhythm, volume and character. Bilateral carotid pulsations could be palpated equal and normal. BP was 130/90 millimeters of mercury, and respiratory rate was normal, and the patient was afebrile. Even on the systemic examination, all the systems were within normal limits. Coming to the ocular examination, normal head posture with no facial asymmetry, and patient was orthophoric, and ocular movements, ductions, versions, and versions were full in all directions. Coming to the examination of the right eye, unaided visual acuity was 618, and on dry refraction, both the meridians were neutralized with plus 2.50 diopter sphere, and on subjective refraction with plus 1 diopter sphere, the vision was improving to 6.6, and his near vision was N6 with plus 3 diopter. Lid margins were healthy, eyelashes were normal in orientation and number, duct orifices were normal, conjunctiva and sclera was normal, corneal epithelium, stroma, endothelium was normal, corneal sensations were within normal limits. Anterior chamber was quiet with Van Herrick's grade 3. The iris was normal in color and pattern with no neovascularization or iris atrophy. Pupil was 3 mm, round, regular, and reacting. Direct reflex was present, and consensual reflex was sluggish. The lens had nuclear sclerosis grade 1 to 2, and anterior vitreous phase was quiet. On gonioscopy, the right eye showed open angles in all quadrants, and with Goldman applanation tonometry, the intraocular pressure at 10 AM was 12 millimeters of mercury. Right eye, fundus examination, distant direct ophthalmoscopy showed a red glow. Slit lamp bimicroscopy with 90 diopter lens, right eye showed clear media with vertically oval disc, normal in size and pink in color with well-defined margins, and CDR was 0.5 with healthy neuroretinal rim, which was following the ISNT rule. Vessels arise from the center of the disc, branching dichotomously, maintaining an AV ratio of 2:3, and macula appears normal, and foveal reflex was dull. Background retina appears to be normal. And slit lamp biomicroscopy findings were confirmed with indirect ophthalmoscopy, and periphery appears to be normal. Coming to the left eye examination, unaided visual acuity was counting finger 2 meter in the left eye, and dry refraction showed a dull glow in the left eye. And on subjective refraction, the vision was improving to counting finger 3 meter with -1 diopter sphere, and near vision was N18 with +3 diopter sphere. Lids and adnexa was normal, conjunctiva and sclera was normal, corneal epithelium, stroma and endothelium was normal, and corneal sensations were normal. Anterior chamber was quiet with Van Herrick's grade 2. The normal pattern of the iris was lost, and there was a tuft of branching vessels superficially at the pupillary margin, suggestive of neovascularization of iris, and pupil was 3 mm, round and regular, but there was grade 1 RAPD, and the consensual reflex was normal. Lens had nuclear sclerosis grade 2, and anterior vitreous phase was quiet. On gonioscopy, there was 360-degree peripheral anterior synec, and in the left eye, IOP was 34 millimeters of mercury. Left eye distant direct ophthalmoscopy showed a dull glow, and on slit lamp biomicroscopy with the 90 diopter lens, the media was clear, and there was a vertically oval disc, normal in size and with well-defined margins. The disc looked hyperemic, and the CDR ratio was 0.6 with healthy neuroretinal rim. Small tortuous vessels were seen on the disc and suggestive of collaterals, and vessels arise from the center of the disc, branching dichotomously with an AV ratio of 2:4. Retinal thickening was seen at the macula and foveal reflex was dull. Background retina shows numerous red, pinhead-shaped and flame-shaped lesions suggestive of deep and superficial hemorrhages in all 4 quadrants. Slit lamp biomicroscopy findings were confirmed with indirect ophthalmoscopy, and the periphery appears to be normal. So coming to the summary, a 67-year-old non-diabetic and hypertensive male patient who had diminution of vision in the left eye for past 8 months came with worsening of vision during the past 1 week. On examination, the left eye vision was a counting finger 3 meter. Anterior segment evaluation showed neovascularization of iris, grade 1 RAPD, and immature cataract. And gonioscopy showed 360-degree peripheral anterior synec, and IOP was 34 millimeters of mercury. Fundus examination showed CDR 0.6 with collateral vessels over the disc, and macular edema was present, and numerous deep and superficial hemorrhages on the retina was present. Right eye had immature cataract. So provisional diagnosis is both eyes senile immature cataract, left eye ischemic central retinal vein occlusion with macular edema and neovascular glaucoma. Baseline investigations, blood investigations.
I think you can stop presenting. And is there any relevant investigation for here? Do you have a field or something like that in the right eye?
So I have OCT and FFA pictures, sir.
I think we can go into discussion here, right?
Okay.
Usually we will finish with clinical examination, right?
Okay.
Yeah, I think we should go into discussion. Yeah.
You can stop your screen sharing.
It's Maya, right?
Yes, ma'am.
Yeah, hi Maya.
Yes, ma'am.
So that's been a very nice and vivid presentation of your case. Fantastic. So let's start from the history. So you now come to a conclusion. We are looking at the left eye central retinal vein occlusions with a neovascularized iris and the neovascular glaucoma here.
Yes.
So what are the risk factors which you ruled out in this particular patient which caused CRVO?
The age of the patient is 66. So age itself is a risk factor, and the patient is a non-case of diabetes mellitus and hypertension. So these are risk factors for
So would you like
CRVO.
to categorize your risk factors which can lead to CRVO, a vascular occlusion?
Like systemic diseases like hypertension, diabetes, then some thrombophilia, inflammatory conditions like sarcoidosis, tuberculosis, and blood dyscrasias like multiple myeloma, then polycythemia, antiphospholipid antibody syndrome, and in young patient, homocystinuria. That is also a reason. And protein C, proteinase deficiency.
Okay, so I think you pretty much have covered most of the risk factors which could lead to. So what do you think was the causative factor risk which caused the CRVO in your particular patient?
Diabetes mellitus and hypertension.
Okay, so
and the age of the patient.
systemic medical diseases which cause a vasculopathy, and so that is probably the primary leading cause in your particular patient.
Yes,
So you
ma'am.
would probably tailor your investigations to rule out the other risk factors which, if had which were not already detected in
Yes.
such patients, would have probably led to or precipitated this thing. So let's go to your examination. Anything you would like to talk to me about your refraction? Can you give me a diagnosis on the refraction of this patient? Normally, it's not asked because it does pertain to you and you do have a separate refract, but something for the all examinees is that when you're giving your refractive errors, you should know, if I ask you what is the diagnosis on the refractive error or what is the name of this refractive error, you should be able to tell us. Yeah. Okay.
Right eye, he had simple hypermetropia with presbyopia.
Okay. And the left?
Left eye, the vision was not improving actually.
Okay, so we are not able to comment. Okay, let's now move on to the examination of the eye now. So can you tell me what are you particularly looking at the examination in an eye pertaining to the case of a CRVO?
The vision of the patient.
Yes.
If
How
it
is it
is
important? Yeah.
vision, if it is less than 6/60, there is higher chance of ischemic CRVO.
Okay.
And if it is more than 6/60, then we can expect a non-ischemic CRVO. And pupil examination, we should look for RAPD. If there is RAPD, then there is higher chance of ischemic CRVO. Then we should look for any neovascularization of pupil as well as gonioscopy to rule out neovascularization of angles.
Anything else before you go to the pupil? Any of the other and the adnexas which you would like to look at in a case of CRVO, a unilateral CRVO? Something we could see in the lids. Can you see something in the eyeballs? The direction of the eyeball?
Like engorged vessels to rule out carotid cavernous.
You might find telltale signs on the lids which are pertaining to the systemic disease. You can have a xanthelasma in a patient who is, hypertensive, who is having a lipid disorder. You could have other, and you could also look for proptosis in patients because that again can cause a vascular occlusion depending upon the lesion in the proptosis, which is probably leading to your vascular occlusion. So these are, particular things when you are saying that your lid is normal, your globe is is normal, then you mean that these are not probably contributing to your to the occurrence of the central retinal vein occlusion. Anything else in the conjunctiva, in the cornea, in the sclera?
Cornea, we should see for
normally you don't find anything. This is a little far-fetched. You might have, if there are cases like you're looking at immune disorders like systemic lupus erythematosus or SLEs, and you might have
dry eye.
But if it's a hypertensive patient, you could look for subconjunctival hemorrhages on the conjunctiva. Of course, these are very far-fetched, but then these are pertaining to the systemic disease which has probably caused the particular condition here. So you delve into your anterior chamber here. In the anterior chamber, anything relating to particularly in the anterior chamber before you go to the iris?
We should look for cells and flare, any inflammation, uveitis.
Yeah, absolutely. So if you're looking at inflammatory diseases which are responsible, like you had a sarcoidosis, you have had a HIV. So telltale signs of these diseases of vasculitis, which could have occurred earlier and which has now which is also presenting as a CRVO. So that's something which you would also like to look at. And of course, you have picked up the NVI in this particular patient here. So just before I hand over to Dr. Nagaraju, can you just tell us why do you particularly see NVI in cases of vascular occlusions? Why does NVI occur in vascular occlusions? When does it occur and what does it lead to?
NVI usually occur in ischemic central retinal vein occlusion. Because of the ischemia, there is production of vascular endothelial growth factors, and due to the production of these angiogenic agents, neovascularization of iris happens, even the angle.
Okay, so when you say that there is
a complication,
yes, So it's a sequential occurrence to a vascular occlusion.
Yeah, yes.
So when you are having a central retinal vascular occlusion, which is particularly grave, why does the iris get neovascularized, and why is it, I think you did not mention any neovascularization in the retina? Did you
Yes,
look at an NVE or an NVD? Is there any particular reason why you would find an NVI
actually,
and not an NVD and an NVE? And if you
yes,
do find, in which kind of vascular occlusions would you find these more commonly?
like ocular ischemic syndrome, we should suspect. Like,
Let's restrict to your case only in a vascular occlusion. So part one is, why have not we seen NVDs and NVEs in this particular case? I'm sorry, I missed on your...
non-ischemic.
Is it because of what was the duration of your pathology in this eye?
8 months, ma'am.
8 months. So it is a reasonable enough time for, so any particular reason why you have an NVI and not an NVD and an NVE? Okay. I think in most of
Anterior segment ischemia.
So I'll just tell you the answer. I mean, to my knowledge, I'm more of a general ophthalmologist rather than like a retina specialist like Gopal here. But I think in NVIs, in CRVOs, the amount of ischemic retina is so high that there is, and the retinal tissue probably has been so damaged by the vascular occlusion that it cannot respond, forming new vessels. So the NVIs commonly are seen here. So if you have lesser amount of retinal tissue which is affected, then that responds to the VEGF, which is prevalent, and that causes NVD. So you would probably see them more depending upon the area of involvement. Of course, as you rightly said, it does differentiate an ischemic and a non-ischemic CRVOs here. Okay. I think we will not particularly go into the depths of these, which is more what is more pertaining to a general ophthalmologist and for a postgraduate level. And I would request Dr. Nagaraju to step in now.
Dr. Maya,
yes,
excellent presentation. From your history, I think the presenting slide which you presented, no? I'm just a little bit confused by the duration and the chronology of the decrease in the vision the patient is having. You told the patient is having decrease in the vision for the past 8 months, which was sudden in onset. Then the next statement you have made is that it is progressive in nature.
It was sudden, sir.
Sudden
8 months back. 8 months back, he was giving the history like he came.
Next, the another statement you have made. Now he complains of worsening in the vision in the left eye into few days. That I am not able to gather. See, patient is having this
maybe
problem
increased macular edema or something might have happened.
8 months the patient is having this problem. You told it is gradually progressing. And how many days? Past how many days? That you should be more specific in your
1 week, sir.
1 week. In past 7 days, the patient complains of decrease in vision. Suddenly, that is why he has presented to somebody else and he was referred to a ophthalmic center.
Yes.
Okay. Why do you think this has happened?
That time itself, means 8 months back itself, he might have had this CRVO, and along with that, he's having a little bit of cataract also. So now the macular edema might have worsened and he might have come to us.
Do you think it is only macular edema which is causing him this decrease in the vision, or do you think it is something else? Okay, I'll give you a clue. Madam asked you about various changes which you can get in the anterior segment in a case of glaucoma. What are things you can get in a case in a cornea? In this case, I'm just think about only
when
this.
There is increased intraocular pressure, there is chances of corneal edema.
What type of edema you get?
Like
Stomal edema?
Epithelial edema, sir.
But you'll get epithelial.
There will be bulle and.
Okay. Did you notice any such thing in your case?
No, sir.
Okay. So probably the pressure must have increased in the past couple of days. That is why you must have presented. That is one thing you should keep in mind. Okay. And next is this gonioscopy. Okay. You were told there is no new vessels in the angle. Okay, that is what I think you have mentioned in your gonoscopy.
There was a 360-degree peripheral anterior synechiae, so angle itself was not.
No, supposing if there is a 360-degree synechiae, how do you tell it is a synechiae? I will tell it is just an oppositional closure. So you should make
We
one
can do indentation gonioscopy.
Not we can do. Did you do it? You should tell. On indentation gonioscopy, I made a diagnosis of peripheral anterior synechiae. Or it could, I can tell it is just an oppositional closure.
No, the chance of a synechial angle closure is more here because the fibrovascular membrane might have contracted and
you not made, when you are doing gonioscopy, you don't know probably it is a case of neovascular glaucoma. You have just seen only new vessels on the iris, not
yes,
in the angle. So that is one thing you should keep in mind. You should tell, I did a indentation gonioscopy, and then there was no oppositional closure. It was a synechial closure. Okay. How do you differentiate between a synechial closure and an iris process? That you should know. These are all basic questions that you read up. All the postgraduates read up.
Okay.
Next is this fundus picture, whatever you have described. No.
Yes,
From the fundus diagram, what type of this thing vein occlusion do you think it is? How do you classify vein occlusions?
Ischemic retinal vein occlusion and non-ischemic. Branch retinal vein occlusion as well as central retinal vein occlusion and hemiretinal vein occlusion.
Okay. What type of vein occlusion is it?
This is central retinal vein occlusion. And the patient...
In a central retinal vein occlusion, where do you think is the block?
Sir, in ischemic central retinal vein occlusion, the occlusion will be at the level of lamina cribrosa, and in non-ischemic, it will be behind the lamina cribrosa, around 6 mm behind the lamina cribrosa, where there are a lot of collaterals.
Okay, you told branch retinal vein occlusion. Which quadrant of the retina the branch retinal vein occlusions are common?
Superotemporal, sir.
Why?
Because of the...
These are undergraduate questions. The answer, there are two answers for this. It's an undergraduate question. Why do you get?
Because of the branching of the vessel pattern, there is direct thrombus.
That is one point. What is the second point?
Non-crossing of the vessels.
There are many crossings at the superotemporal branch. That is another reason. These are the two reasons why you get more of superotemporal vein occlusion rather than branch retinal vein occlusions in other quadrants.
Yes.
So next is take all the history and your clinical findings, and what you told, you made a diagnosis of central retinal vein occlusion. I want you to tell me whether it is a ischemic or non-ischemic type.
From my clinical examination, I came to a diagnosis of ischemic central retinal vein occlusion, sir.
Why do you say it is ischemic?
Because the vision of the patient is very less, and the patient had RAPD, anterior segment findings. He had neovascular features of neovascular glaucoma, which usually occurs in ischemic CRVO.
Okay. What are all the other changes in the disc which are very important in a case of vein occlusion?
Disc edema.
You see a vein occlusion, either whether it is a branch vein occlusion, hemicentric vein occlusion, or a central retinal vein occlusion. You just have a look at the disc. Looking at the disc, what are all conditions you want to rule out?
Disc edema. Then, sorry, sir.
Why disc edema? Why is the examination of a disc important in a case of vein occlusion? More common in a case of branch retinal vein occlusion, we tell you to look at the disc. Why?
The site of occlusion can be...
No. What other conditions you try to...
No, glaucoma. Glaucoma itself is a risk factor for...
Glaucoma, there are so many books on glaucoma, Blue Shields and all those things. We should tell what Becker-Schaffer, which glaucoma you should tell. Open angle glaucoma. It is more common in case of vein occlusion. Examination of the disc is important.
Yes.
Why do you want to examine the disc? Risk factors, madam was asking you, no? Those risk factors can also manifest in the disc. What this thing you can make out? I will tell those whatever you told, no, those collaterals. I will tell it is a new vessel on the disc.
Collaterals will be looped vessels which do not branch and will not leak in FFA.
Okay, okay. So that is the reason to know the etiology. You should know whether it is, you can see whether there are hypertensive changes in the retina. Do you see any hypertensive changes in the retina?
The arteries were attenuated, sir, in that.
Can you just show me which is the artery, which is the vein here?
You need to probably share your presentation.
Okay, it doesn't matter. You just see that. See, you should know how to describe an artery and how to describe a vein. Okay.
Yes, sir.
In this case,
The
you can
caliber.
see that glinting reflects on the vessel. You can make out prominently because of the thrombosed vessel, because of the backlog. Can you tell me what are the AV crossing changes you get in a case of hypertensive retinopathy?
Gun sign.
What is gun sign? These are all common things which the examiner will ask you. So all those things you read up. Gun sign, Salu sign,
Salus sign.
all those things you should know. Okay.
Nice. Okay.
So all those things you should have described that also, those findings. See, you all of you made a very good description of the fundus. Whenever you describe a fundus, you describe the disc in detail.
Okay.
Next you describe the macula. Next is the vessels. Last is the background retina. All of you have done that. You keep in mind so that you will not miss out anything.
Okay.
So basically, whenever you see a pathology, you will go directly to the pathology. You will miss the other things. Okay.
Okay.
So you tell it is an ischemic vein occlusion. I don't see many cotton wool spots over here. Can you see? I don't think there are any cotton wool spots anywhere.
No, sir. Actually, this have happened.
What type of hemorrhages are there? What type of hemorrhages are there?
Flame shaped as well as dot and blot hemorrhages.
Why do you say it is a flame shaped hemorrhage?
Flame shaped hemorrhages occur in retinal nerve fiber layer. So it will take the.
See, basics. All of you should know the basics. You should know what is, how to describe a flame shaped hemorrhage, how to describe a dot hemorrhage, how to describe a blot hemorrhage, how to describe a microaneurysm, how to differentiate between a dot hemorrhage and a microaneurysm. You should know what are all the AV crossing changes. Supposing I will ask you what are the red lesions in the fundus, you should try to list out all the conditions which produce red color in the fundus. All those things you should try to tell. So cotton wool spots you are not able to see in this case.
No.
Okay. So your diagnosis is a neovascular glaucoma.
Yes, sir.
Okay. What is the prognosis in this case?
The prognosis, vision is less now. And
the patient has come to you with a problem, decrease in the vision, and I don't think he has got any pain, decrease in the vision. Main thing is his complaint is decrease in the vision. He comes to you with an expectation that he wants to see properly.
Yes, sir.
Yeah. What are you going to do for him?
The first thing is systemic evaluation to rule out the causes for this condition.
No, all those things you have done, and you have written all the findings there. You have done a systemic evaluation. You are going to control all those things. Yes. Next is you come only to the ocular management. We'll discuss only the ocular management. Forget the systemic factors.
We have to treat raised IOP, macular edema, as well as neovascularization in this patient. So first thing is control of IOP.
Yeah, very good. How do you see? One is control the patient. Why is the intraocular pressure raised due to?
Because of the angle closure.
Angle closure. Okay, because of the neovascularization. Okay.
Yes, yes.
Next, how are you going to reduce that intraocular pressure in this particular case?
Here the IOP of the patient is 36 millimeters of mercury. So we'll start with systemic carbonic anhydrase inhibitors, which reduce the production of aqueous. So we can aqueous suppressants. And topical medications like beta blockers, like timolol 0.5%, and beta agonist, alpha agonist like brimonidine, and topical carbonic anhydrase inhibitors like dorzolamide can be given for the patient.
Can be given. What are all the anti-glaucoma drugs which you don't want to give to reduce the intraocular pressure?
Prostaglandin, here the patient is already having macular edema. So if we are giving prostaglandin, then there is increased chance of increase in macular edema, and myotics should not be given, increased chance of inflammation.
In this case.
Yes.
Okay, that is good. Next is, you will see from whatever history you have told, the lens changes are, I think, very minimal in your case.
Nuclear sclerosis grade 2.
Okay, so you can see everything normally, what is happening in the behind the lens on the retina. So now, what are you going to do for the management? Other than you reduce the intraocular pressure, what are the glaucomatous topical medications you give to this patient in addition to the anti-glaucoma medication to the left eye?
Topical medication.
Non-glaucoma topical medications.
Nepafinac.
No.
It is
Any other powerful anti-inflammatory? We don't usually, we require more powerful.
like steroids.
Topical steroids you can
Topical
give to reduce the inflammation. Next. You told it is a glaucoma. What type of glaucoma is it? Primary angle glaucoma, secondary angle?
Secondary angle closure glaucoma.
How do you classify a secondary glaucoma? General classification is secondary.
Secondary glaucomas can be open angle and closed angle glaucomas. Here closed angle glaucoma.
It is a
secondary closed angle glaucoma.
Secondary to neovascularization.
Secondary to neovascularization.
Even though it is a closed angle glaucoma, you can give atropine also to reduce the inflammation and all those things. You can just give atropine also in the meantime. Okay. Next is that is you manage the management of intraocular pressure. Next is how are you going to manage the vein occlusion?
Vein occlusion. There
When
is
systemic,
macular edema.
somebody is managing. You are not managing the systemic part. Somebody is managing it.
Yes.
You feel that everything has been managed systemically. Patient systemic condition is normal. Is almost made to come to normal levels.
Okay,
now you are going to think only on the ocular management of
yes, sir.
What you want to do.
We have to manage macular edema and neovascularization. So the first thing is do pan-retinal photocoagulation.
Is there any neovascularization in your case? On the retina? Madam was asking you.
On the retina.
On the retina,
sir,
is there any...
No, on... we have to move ahead with the fundus fluorescein angiography to roll out.
Put the fundus picture there also. What is there in that fundus picture?
There were no much neovascularization.
So you didn't see any neovascularization at all there. No, okay.
No,
so whatever you see on the disc, it is just a collateral. So there is no new vessels in the retina.
I see.
Now, how are you going to manage? What are the various modalities of treatment of?
Intravitreal anti-VEGF injection should be given, sir.
Yeah.
Like
the anti-VEGF medication.
Like ranibizumab.
Don't mention any brand names. All the tongue-twisting anti-VEGF names you just buy out and you just let that tell with the proper dosage you tell. Okay. Due to lack of time, we're not going to the details. So you should mention the pharmacological names with the dosage correctly. So one is
ranibizumab, 0.5, then 0.5 per 0.5 ml.
Okay. Sensitivity medications, what do you do?
Sorry, sir.
You are given an anti-VEGF injection. Next, what are you going to do? When are you going to see the patient? And when do you know your medications are being effective?
Like every 2 weekly, we have to follow up the patient.
Okay. And what are things?
And we should look for IOP. In this patient, already there is an
IOP reducing with the medication. What is the cause of decrease in the vision in this case?
Macular edema, sir. So,
how do you diagnose macular edema in this case?
OCT can be done for the patient.
What do you make out on OCT? Have you done OCT in
yes,
this
sir.
case?
Yes, sir.
You just tell. How do you tell there is macular edema?
Foveal contour will be altered and there will be cystic spaces.
Can you make out any edema there? Can you see the macula there in your case, in your fundus picture? Macula is not clearly visible at all. Okay, the macular reflex is not there at all, no?
Yes, sir.
Okay, so probably there is some pathology in the macula. Probably it is edema. Looking at the extensive hemorrhages there. To confirm it, you are going to do an OCT. And how are you going to tell that there is macular
foveal
edema?
contour will be altered and central retinal thickness will be increased and there will be cystic spaces within the inner retinal layers.
What will be the normal thickness?
Around 250 micrometers.
Yeah, anything more than 270, 280, you should keep in mind that there is macular edema. So what are the other alternatives? You give anti-VEGF, you monitor the patient. Then what are the other modalities? Which other intravitreal medications can be given?
Steroids, sir. Other than anti-VEGFs, steroids.
What are the steroids intravitreally?
Dexamethasone, intravitreal dexamethasone 0.7 milligrams.
Any other steroid which can be given?
Triamcinolone, intravitreal.
So whenever you give a steroid, what are things you look for? You're managing the
Acute rise in IOP.
So monitoring the intraocular pressure is very important. Okay, you do all these things and you wait for a couple of weeks, 6 weeks, 8 weeks, the pressure is still high, the retina looks stable, and supposing if you find, supposing in this case on gonioscopy, if you had noticed some new vessels in the angle, what else extra you would have done in this case? I want those iris vessels to go. I want those new vessels on in the angle to go. What are you going to do?
PR.
You can do a PRP. You can do a PRP. See, in this case, how are you going to do a PRP? What are all the areas on which you will not put the laser spot?
Macular area will not put lasers.
Akila, not seeing at all there.
When will you do a PRP? What is the timing of your PRP?
Yeah, the timing of your PRP.
Central vein occlusion study says that we can wait until there are 2 clock hours or of iris neovascularization.
Okay. I think we are running out of time.
Yeah. I think we should go on to the next case.
Okay.
All those things you can ask Dr. Gopal. He is more of a retina person.
Yeah. I basically have a feeling that this was originally a non-ischemic CRVO, which has become ischemic in the past short period. I think we'll
That
go
is the
on.
reason probably we don't see so many cotton wool spots also.
Yeah.
Yeah.
Exactly.
Okay.
Who's the next presenter?
It's time. I think we should move on to the next case.
Excellent.
Thank you, Maya.
Excellent discussion, Dr. Vanati and Nagaraju sir. Excellent.
Thank you, sir. Thank you.
Good presentation,
Ramya?
Maya.
Yeah,
Now
yeah.
let us go to Ramya.
Ramya, you can share your screen.
Yes.
Which case is this?
Sir, proptosis.
Okay.
We are now 10:22. Probably we can 10:23. We can go till 10:45.
Yeah.
50.
10:50. Yeah.
Dr. You are good. Dr. Ramya, you do one thing. You try to make a very brief history presentation. What all things are normal. You don't try to tell everything. You tell it is nothing contributory on systemic examination, something like that. Those slides you can just make a brief thing. Start.
Good morning. I'm presenting a case of a 35-year-old gentleman from Todupuzha. He presented with prominence of right eye for 1 year and history of present illness. He was apparently normal male when he noticed a gradual outward protrusion of the right eye since last 1 year. Now it is associated with a mild aching pain in the back of the eye since last 3 months. The outward protrusion was gradually increasing over the last 1 year. It was not associated with any blurry vision or double vision, nor was there any postural variation noted or any diurnal variation noted. There was not, he didn't complain of any redness or discharge in the eye. There was no difficulty in moving eyes. There was also no weight loss, night sweats, or heat or cold intolerance, which he was complaining of. His past ocular history was unremarkable. And in the past medical history, he didn't have any medical illness in the past. There was no history of weight loss, weight gain, heat or cold intolerance, no excessive sweating or tremors, no other lumps in any other part of the body. Drug history was unremarkable. He was not on any drug. His personal history was also normal. Sleep and appetite was normal. Bowel and bladder habits were normal. He didn't have any addictions. General examination, he was conscious and oriented and was moderately built and nourished. No pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. His pulse rate was 80 per minute and it was regular and he was afebrile and rest of the systemic examination was within normal limit and no thyroid or megaly was noted. Ocular examination, head posture was normal. Ocular posture was orthotropic by Hirschberg test confirmed by cover uncover test. Pupil showed grade 1 RAPD in the right eye. Visual acuity, unaided vision in the right eye was 6.6 N6 and the left eye was also 6.6 N6. His retinoscopy was showing 0.5 diopter cylinder at 90 in the right eye and 0.5 diopter cylinder at 110 in the left eye, and his BCVA was 6.6 N6. Color vision was 21 by 21 both eyes. Coming to orbital examination, on inspection, his head posture was normal, but because of the right eye proptosis, and there was right eye axial proptosis determined by Knapziger's method and confirmed by worm's eye view. Ocular motility was full and free in all directions. Eyelids were normal, and there was no periorbital inflammation. There was no lag of ophthalmos, and he had good Bell's phenomenon. On palpation, the retropulsion was positive. No orbital thrill or pulsation was felt. No swelling was felt around the eye, and the orbital margins were intact. And I could insinuate a finger between the orbital margin and the globe, and no other masses were palpable. He didn't have any tenderness. No lymph nodes were palpated, and there was no infraorbital or supraorbital anesthesia noted. Exophthalmometry by Hertel's exophthalmometer with base 105 showed right eye 23 millimeter and the left eye it was 19 millimeter. Confrontation was done and it was normal. And anterior segment examination, lids and lacrimal apparatus were normal. Conjunctiva was normal in the right eye. Cornea was normal. Sclera was normal in both eyes. Anterior chamber was Van Harris grade 4 in both eyes. Anterior segment examination of the right eye didn't show any conjunctival congestion, episcleral congestion, or any lid edema or congestion. There was no conjunctival mass also noted. Pupil in the right eye showed grade 1 RAPD, and the left eye it was normal. Iris was normal in color and pattern in both eye. Lens was clear in both eye, and IOP was also normal, 10 millimeter of mercury in both eyes. Fundus examination in the right eye, media was clear and red glow was present. With slit line biomicroscopy with 78D lens showed elevated disc with hyperemic margins, and the disc margins were blurred. Vessels were also blurred and tortuous, and rest of the fundus examination was within normal limit. In the left eye, disc was normal in size and shape. Media was clear, red glow was present. Disc was normal in size and shape with cup disc ratio 0.2. Vessels were arising centrally and were branching dichotomously with an AV ratio of 2:3. Macular foveal reflex was present. This is a fundus picture of the patient showing right eye disc edema. This is a 9-gaze picture of the showing. There is no restriction of mobility. There is no EOM restrictions. And the right eye proptosis is clearly seen with this worm's eye view. This is a fundus picture showing the disc edema in the right eye. To summarize, this is a 35-year-old male with progressive increase in protrusion of the right eye over last 1 year, and on examination, axial proptosis of the right eye was noted with exophthalmometry reading showing 23 millimeter in the right eye and 19 millimeter in the left eye with a base of 105 millimeter. Vision BCVA was 66N6 both eye with a grade 1 RAPD, and anterior segment examination was within normal limit. Fundus was in the right eye was showing disc edema. So he is having axial proptosis with a compressive optic neuropathy. My differential, the most common cause of axial proptosis being thyroid-related ophthalmopathy is my first differential. But other causes of intracorneal mass lesions, since he is not having much of inflammation, intracorneal mass lesions like cavernous hemangioma, optic nerve meningioma, optic nerve sheath schwannoma, circumscribed lymphangioma, and orbital lymphoma should be ruled out. So he needs to be investigated further to come into a proper diagnosis. Thank you.
Over to the examiner's discussion. You can stop sharing your screen, Ramya. Yeah.
Yes, ma'am.
Anati, madam, you are muted.
Sorry, yeah. Thank you, Ramya. So quickly, for the benefit of the postgraduates who are listening to this, can you just elaborate the various signs which you would see in proptosis?
First, it should be assessed by Knapziger method. In the Knapziger method, we will stand behind the patient and will gaze towards the chin from the forehead. Then there will be elevation of the eyeball beyond the orbital margin in the affected side. That is Knapziger method. By worm's eye view, we view from the below the patient while the patient's head is tilted backwards, and then we'll examine whether there is protrusion. And it can be confirmed by exophthalmometry measurements by using Hertel's exophthalmometer, or Nagel's or Ludel's exophthalmometer can be used.
What are the other
This is
signs?
how we assess proptosis.
Okay, so all signs related to thyroid ophthalmopathy, a thyroid eye disease?
Yes, ma'am. There are lid signs. Conjunctiva will be usually edematous. There will be congestion and there'll be lid will be edematous. There are lid signs like Dalrymple sign, where there is lid retraction, Mongraphy sign, when there is lid lag on down gaze, then Stelvag sign, infrequent blinking, Cocker sign, staring look, then Ballet sign where there is EOM restriction, then Braille sign when there is IOP restriction in up gaze. These are few signs of thyroid ophthalmopathy.
How many signs are there in this thing? Thyroid. See, thyroid eye disease is one disease. It has got many names.
Yes.
Even the thyroid eye disease itself, exophthalmos, bacillus disease. Likewise, I have made a list of around 28 signs, clinical signs in this thing. I'll share it with Dr. Gopal later on. Okay. So,
Okay, sir.
common things you should see. Did you notice any of those signs in your patient?
No, sir.
Which is
There
the
was no
commonest
lid
sign?
lid retraction.
No, which is the
Lid
commonest
retraction.
sign?
Lid
No.
retraction, sir.
More than lid retraction, there is another sign which is more
Proptosis.
common in thyroid. Huh? No.
Proptosis.
What is Mobius sign?
Mobius sign is difficulty in convergence.
That is one of the earliest signs which you can see in thyroid ophthalmopathy.
Okay, sir.
Okay. See, what are the points in your history which tell us that it is not a thyroid eye disease?
First
On
of
your
all,
examination. In your
sir.
examination, there was one clinching point which probably tell us it is not a thyroid eye disease.
There were no signs of inflammation the patient were telling. He didn't complain of any redness
No,
or
only
any
signs.
signs. There was no lid retraction and it was axial proptosis. There was no EOM restriction. Extraocular movements were full in all directions. And
there was something there which will not be there in thyroid eye disease. Whatever history you presented, no? In one of the slide, what did you tell about retropulsion?
Sir, retropulsion will be positive in thyroid ophthalmopathy and also in orbital tumors.
Now, what do you mean by positive?
Means we will feel a resistance when we are pressing into the globe.
You felt a resistance, or
yes,
did
sir.
the
Yes, sir.
no? I
yes,
thought
sir.
positive means when you applied pressure, the globe went in
no,
easily.
Sir.
That is what I felt.
No, sir.
Okay.
It is like you felt a resistance when applying pressure.
Okay. Then.
And there was no episcleral congestion, no lid edema. There was no lid signs and no lid lag or EOM was full. So, since
what is the commonest cause of unilateral proptosis in a 30-year-old
thyroid ophthalmopathy?
What is the commonest cause of unilateral proptosis in a 50-year-old man?
50-year-old man, thyroid ophthalmopathy should be
What is the commonest cause of bilateral proptosis in a 30-year-old male, 30-year-old female?
30-year-old female is thyroid ophthalmopathy.
Commonest cause of bilateral proptosis in a 50-year-old male? That is also thyroid eye disease. Thyroid ophthalmopathy is one of the commonest cause of unilateral and bilateral proptosis. So, of course, that is your first diagnosis. You should rule out thyroid eye disease. Other than thyroid eye disease, you see there are other signs and symptoms of thyroid eye disease, systemic and ocular, which are not present in your case. That is what I feel. So then you forget thyroid eye disease. Then you try to see what other diagnoses are there.
Since he's a young male and he's having axial proptosis, other intracorneal mass lesions like hemangioma, cavernous hemangioma, optic nerve meningioma, schwannoma, and orbital lymphoma also should be ruled out. So we need to investigate him further to rule out all these conditions. CT and MRI should be taken and the blood routine examination should be done.
So, what is the vision in your patient? What is the vision?
He had BCVA 6/6 and 6 both eyes, sir.
Both eyes. Vision is not affected.
Not affected.
Young
only
patient,
grade 1 RAPD.
Patient is having proptosis.
Yes, sir.
Vision is normal.
Yes,
okay. So how are you going to make a diagnosis in this case? The definitive diagnosis. How do you make a definitive diagnosis in a case of proptosis?
So he needs to be his blood routine examination and also thyroid profile should be checked and the thyroid antibodies should be checked.
Have you done all
yes,
those
sir. Sir, that was within normal limit.
Everything
and he was
normal.
imaged.
Okay.
He should be imaged. CT or MRI should be taken to rule out any mass
lesion. You want to take an MRI?
Sir, MRI would be more useful because soft tissue lesions are more delineated by MRI.
No, okay. Supposing if this patient was having a decrease in the vision, what investigation you would have thought of first?
Sir, HFA can be done to look for if there is any field test, means any field defect.
Imaging.
Sir, Sir, MRI should be done to rule out if there is any optic nerve compression.
Here, I think a CT is just good enough to make a
Okay.
diagnosis.
Okay.
You don't have to think of getting an MRI done.
Okay.
The CT is also very good. Okay. Then,
Sir.
can you do an orbital B scan?
Yes, sir. If it is orbital B scan. Yes, sir.
You can get an orbital B scan done also.
Yes,
What are all the things you can make out in an orbital B scan?
Orbital B scan, the mass can be delineated. If it is hyperechoic or not, that can be determined. And if the well-defined or not, if the margins are well-defined or not, that can be delineated. And whether it is pushing on to the optic nerve or other EOMs and other structures, that
Was
can
there
be
any history of trauma in this case, ma?
No, sir. No history of trauma.
Trauma, okay. Can you think of any vascular lesions also other than your cavernous hemangioma?
Yes, sir. Carotical cavernous fistula is a possibility being proptosis, but there is no other acute signs like any congestion or pulsating proptosis was not there.
Did you check about any change in the proptosis with different posture?
Yes, I checked. There was no change in proptosis, sir.
Supposing if there was a change, what do you think might be
Orbital varices can be considered.
Okay.
So that produces change variation.
The second differential diagnosis in the intracorneal mass lesion, you mentioned optic nerve sheath meningioma and optic nerve sheath schwannoma.
Yes, sir.
They also can produce
axial proptosis.
Okay. So how do you make out a patient having proptosis? Very minimal proptosis the patient is having. How are you going to? You told two signs: worm sign and Navziger sign. Is there any other sign? Some rule test, Kestenbaum ruler test you have seen? Know about that? You can keep a straight edge between the upper and the lower orbital margin with the patient asking to look straight ahead. Supposing if it touches the closed eyelids, it indicates the patient is apparently normal. In the case of very minimal proptosis, you will not be able to touch it. It will just jet out on one side. That is one thing you should know. So you mentioned about exophthalmometry.
Yes, sir.
What were the readings you told?
So 23 in the right eye and 19 in the left eye with base 105 millimeters.
What is absolute exophthalmometry?
Sir, absolute means we compare with the normal of the age group. Relative means we compare with both eyes.
Do you think it is abnormal in this?
Yes, sir.
So your relative exophthalmometry is more on the right side compared to the left side. Okay. Okay. Can you mention any other simple exophthalmometers?
Sir, Ludels is there.
Spelling?
L-U-D-D-L-D.
No. You have had another L there. It is just Lutz, I think, from as far as I know. Have you seen that?
No, sir, I have not seen.
Okay. That is a simple thing which you can use in most of the thyroid eye disease. It is a simple instrument, very non-expensive exophthalmometer. It is very easy to use also. Lutz exophthalmometer. Okay. Next, what other exophthalmometers are there?
Nagel. Nagel's exophthalmometer.
Supposing the patient has undergone an orbitotomy.
Yes, sir.
And in those cases, what type of
Nagels only, because it rests on the superior and inferior margins.
Even a Gorman's exophthalmometry can also be used in such cases. Okay. So you should know the various exophthalmometers. Okay. So in this case, I don't agree with your diagnosis of thyroid eye disease as well.
Yes, sir. Yes, sir.
Okay, and that thing is confirmed by your systemic thing also. Yes, and you have got an imaging done, CT scan done for this patient?
Yes, sir, I have it.
Can you share the picture? Yes. Later on, you can share it in the group. It doesn't matter. If there is lack of
can
time,
you see it now?
Yeah, I'll just see, ma.
As you're sharing.
Supposing if it is a thyroid orbitopathy, what do you feel will be the changes there? Your first diagnosis is thyroid orbitopathy.
Yes, sir. Hello, sir.
Yeah, tell me.
Sir.
If it is a thyroid eye disease causing proptosis unilateral in this patient, what are all the changes you see?
Sir, can you just repeat the question, sir? I didn't hear properly, sir.
Okay. So your diagnosis is thyroid eye disease.
Okay, sir.
CT scan has been done for this patient.
Yes,
CT
sir.
scan is in front of you. You share the screen. And what all things your clinical diagnosis is thyroid eye disease. What all things you look there?
In the CT.
CT. To
That
confirm your
extraocular
diagnosis.
extraocular
Can you share the
muscles will
screen?
be.
Can you share that picture?
It is not seen. Just a minute, sir.
Okay, keep on talking, ma. Keep on answering the question while you
Sir,
try to
is
share.
it now visible, sir? Is it now visible, sir?
Yeah. It is visible,
Yes, it is.
Ramya. Yeah.
Can you enlarge that, ma?
Screen show pe डाल
Okay,
देना.
anyway,
Put it on screen show. Yeah. Right side lower. Yes.
Okay. Anyway, the delusion
It's
is very
okay.
obvious
Yes.
there.
Yeah.
Okay, supposing if it is a thyroid eye disease, what all things you think would have been seen there? Can you
Sir,
just go back to the city? Go back to that film, ma. Now you can see a white blank there.
It's
Okay,
not
keep on
coming
answering the
on.
question.
You can put it on in
Anyway,
the. You can just talk. It's okay. We've
Yeah,
already
yeah.
seen the picture.
Yeah.
Yes.
In a thyroid eye disease, what are the CT changes?
Sir, extraocular muscles will be thickened. It will be thickened in a spindle-shaped manner, which thyroid, the tendon will be shared. The tendon will be spared, and also there will be soft tissue enhancement will be there. Crowding of the apex will be there, and if there
Did
is
you see those things in your case?
Sir, crowding of the apex was there. No extraocular muscle thickening was noted, but there was an intracorneal globular mass, homogeneous mass noted. In the MRI.
No, I'm not talking what you are seeing there. Did you see any thyroid eye disease changes there on the CT?
No, sir. No, it was not there. No EOM thickness was noted.
But your diagnosis of an intracorneal mass causing proptosis is right.
Yes,
so, are there any other causes other than the lesions which I mentioned there? Any inflammatory causes?
Sir, orbital inflammation can cause proptosis, but then there will be other inflammatory signs.
Diseases which can produce?
Yes, sir. Parasitic inflammation can produce.
What diseases? What conditions?
Sir.
Did you ask for history of any pets in the house?
No, sir.
That you should take the history.
Yes,
okay. That also. What are the diseases which can occur in the orbit secondary to parasites? Your cystitis, cyst, all those things you should keep in mind.
Yes, sir.
Okay. So now there you didn't see anything. Supposing if the tendon was involved,
yes, sir.
You told the muscles will be thickened. Okay. The tendon will be spared in a case. If it is involved, what do you think will be the cause?
Myositis can be the cause.
So any orbital inflammatory disorders can produce these conditions. So in your case, there was no orbital inflammation. The patient was young individual, asymptomatic, vision not affected, only a cosmetic blemish of having a proptosis without any postural variation, axial proptosis, which is slightly reducible. That is what I think you told me. No? It was compressible. That is what you told, I think, no?
Sir, resistance was felt while compressing.
Okay, resistance. Okay. These are the things. So you think there is an intracorneal mass. Intracorneal mass, what are the probable causes other than your thyroid conditions?
Intracorneal mass, axial proptosis, it can be due to cavernous hemangioma or meningioma, then circumscribed lymphangiomas, then circumscribed lymphangiomas, orbital lymphoma can be a cause. Then if it is not non-axial, then lacrimal gland tumor can be there. Then
no. In this case,
only these are the
lymphoma also is very unlikely in this case, in this particular age group, to think of that as a primary cause. One. Second thing is the patient, 30-year-old man, only for the past, I think 1 year, I think you told me, no?
Yes, sir. He has noticed only since last 1 year.
Why do you think it has occurred in the past 1 year?
It must have been there. It must have gradually increasing in size, which he has noticed since last 1 year.
No, past couple of years he must be having this. Only past 1 year is having this complaint.
Yes, sir.
Did you tell the proptosis was progressing?
He told that it was slowly increasing over the last 1 year.
1 year, okay.
Yes, sir.
Yeah. Have you got a fields done for them? For this patient?
Field was done within normal limits.
It is
That's
normal.
why I didn't.
Fields, vision, everything is normal.
Grade 1 RAPD was there.
RAPD. Did you check for color vision, ma?
Yeah, color vision was also normal, sir. 21 by 21.
Check whether there is any optic nerve compression in this case.
First, we have to determine if there is any vision loss. Then we have
vision,
to do.
I think is normal in this case.
Yeah. Then pupillary examination should be done, and also color vision and
pupils
field
were
test.
Abnormal in this case.
Yes, sir. Grade 1 RAPD was there. and field examination can be done to rule out any compressive optic neuropathy.
This color, how do you assess the color vision when you suspect an optic nerve lesion?
Sir,
This
by
shows extensive edema.
sir, disclose edema is there, disc edema is there.
How do you check the colors in this patient?
Color vision can be checked
How do
by
you check?
Ishihara's chart. Uniocularly, it is checked.
How do you
And-
check for color vision in a uniocular this thing? In this case, we're using Ishihara chart. Is there any other simple method? How do you check? You should check for color desaturation, ma.
Yes.
Red-green color desaturation.
Okay.
I think that is more important.
Okay.
Huh?
Okay.
How do you check for color desaturation? For optic nerve, all those things you should know. Use a red
green
colored object
filter
or a red colored object or a green color object,
Okay.
and try to compare the vision in the color changes on both the sides. That is more this thing. So, yeah. Next.
Can I just ask one closing question before we move on? Yeah. What is pseudoproptosis?
Yeah.
Ramya?
Pseudoproptosis is not real proptosis. It can be produced due to axial myopia and then lid retraction and the other eye enophthalmos or any increased glaucoma. Like
Commonest condition
buphtalmos,
you would find pseudoproptosis in?
buphtalmos.
Something which is more common when you have a diagnosis of ophthalmos usually, but otherwise common is pseudoproptosis.
Axial myopia.
Absolutely, yeah, it's very common when you would have. So just because you are so good in naming everything, what's the pseudo one graphy sign? Where would you find it?
Ma'am, in aberrant regeneration of third nerve.
Wonderful, yeah. Okay, I think. Gopal has sounded the bell now, so
You can go on to the next.
Yes.
Who's presenting next?
Thank you, Ramya.
But I think you should. I mean, she answered really well. Congratulations, Renia. You actually answered almost all the questions very well. But I think you can, in 2 minutes, both of you can just sum up some, constructive criticisms as to how she can become better.
Okay, yeah. I think the candidates had prepped really well pertaining to their cases here. And something which is most important and which all of them till now showed is they were very relaxed, they were very cool, they're very confident. And the way they speak, it's not important that you have to use flamboyant English. You could just use simple English and use your language should be pertaining to scientific terms. That's a common mistake which most of them tend to make. And I think Dr. Nagaraju also nicely pointed out, when you're talking about symptoms, don't use language which is pertaining to science. And that sort of tells that you've been tutored before your case. So that's something which is important when you're presenting. And present in such a way that it is leading the examiner on to points that you know, and which will encourage the examiner to ask points in which you would be confident in answering. So that's a very good tip which I would give to all my examinees here, all my residents, and it always helps the positivity in your presentations to go on, to feel confident and the way you are answering. If you do not know something, please don't sort of guess too badly, and that would really make you get caught. And you would further and further dig a grave for yourself and keep falling, because the examiner now knows what you do not know, and it will be very easy for him to put you down easily. So, not all examiners would have a positive approach, or the way of examining will be different from person A to person B. So don't get put off by the way a person is examining you. Always stay confident and have a smile on your face. Don't show the tension. Of course, it's not easy. Don't show the tension on your face. And a nice smiling face, a confident reply, the way you articulate your vocabulary, it goes a long way in giving you a lot of plus points. And I think heads up to all those who have presented till now. Dr. Nagaraju.
Yeah, all of you have done a wonderful presentation. One thing I want every one of you to do, probably what I did during my post-graduation day, most of the time we know what are the type of cases which are usually kept in the examination. I want all of you to prepare a template and keep everything ready, especially the examination part. No, supposing if it is a case of proptosis, if it is a case of uveitis, open angle glaucoma, a nerve palsy, you prepare a template and a cornea case. you just write all the columns there. Only thing is, when you sit in front of the patient, you examine the case, you write only the positive points there. You don't waste time sitting in front of the patient, writing normal, normal, normal. You just, the important positive clinical findings you mentioned there. And later on, when you go outside, you can sit there, sit and write the other findings. And once you have a complete template ready with you, and you prepare a template today itself, you're all in your second year. I think one more batch is giving examination shortly, sir. Anybody is giving the examination? Probably the exam going students.
The DNB examinations, new DNB examinations will be just from the corner.
Yeah.
And
so
the other batch
probably those
April,
children will be having, they had a lot of loss of this clinical touch for the past 1 year because of this pandemic. Probably they will be more exposed to, probably they will be given a virtual case only. Probably for the second years, probably next year, once the pandemic is under control, you'll be given a case itself. So it will be easy for you. In a virtual presentation, it is more difficult because basically it will be more of a theoretical examination. In a case, you will have a lot of time. Sometimes the examiner will ask you to elicit signs in front of the patient. So it will be easy for you. Don't be tensed, be very relaxed and be confident of your answers. Supposing if you don't know, or if you don't understand a question, you just tell, sir, pardon sir, or pardon madam, and you can just pause and never try to guess and never try to outsmart the examiner. Sometimes what will happen, you try to tell whatever you know, whatever is asked, you should tell. And like madam said, you can try to lead the examiner to the area where you are well versed or where you are well read. I think that will this thing with the time, experience, and whenever you are free, you keep on presenting cases in the every day, at least in a week, once or twice. If you present a case in the examination, it will be easy. Most of the time you try to present only, many students, they present a case on the day of the examination. For them, it will be difficult. If you keep on presenting frequently, then it will be easy for you people to face the examiners. And most of the examiners are not pen ophthalmologists in the present era. Some of them will be well versed in a particular subspecialty, yes. And basically you will be well read with them compared to them. Only thing is this examination is basically conducted to know whether your basics are right. That is the main thing. Supposing if you don't answer a very rare question, will not fail you. Supposing if you make a basic question, you write a retinoscopy reading of +4 and you tell it is a myopia, then we will not be this thing, because most of the time, the cases are kept there, cases are admitted there, the cases are being seen by everybody. Only thing is the interpretation of the findings. We are not bothered about the diagnosis. We are only bothered about how you come to a diagnosis and what is the flow of thoughts. Okay, we are all doing well. I think we will definitely improve. Yeah. All the best. Next presenter, please.
Gopal, can you just share the number of views on YouTube at present, if you have the numbers?
Views, 500. Okay, I'll just share that. So this is the.
I think my postgraduate.
Which is there 497 playbacks. 497 playbacks.
Oh, that's excellent. So I presume most of them are postgraduate students, and they'll be really benefited by this. Vanity madam, you are muted. Vanity madam, you are muted.
Yeah, anything, that's excellent, Gopal and Dr. Sai. Anything the postgraduates want to ask us before we move on? Anything they would like us to address, or just feel free to talk and interact. We are always here. If not, then we can just move on.
Okay. So I'll put that message on YouTube, so that if some of the PGs want to ask some questions, I will relay to you. So over to Leia for the next.
Please share your screen, Dr. Leia.
Oh, okay, sir. Sir, is it visible?
It is. It's visible. Yes, Dr. Leia.
So first of all, I would like to thank my teachers and my mentor for giving me an opportunity to participate in this platform. And I would also like to thank my examiners also beforehand. And with due respect, I'm sorry that my most important picture, that is the primary gaze picture for my patient, is not there in my presentation, but the 9 gaze pictures are there. So this is my case. He's a 73-year-old male who is from Aluva. He's a businessman. He presented with double vision for 7 days and drooping of left upper eyelid for 3 days. History of presenting illness, the patient was apparently normal 1 week back, after which he gives us double vision, history of double. 1 minute. Okay, after which he gives us a history of double vision, which was sudden in onset, painless, and sees as 2 objects horizontally separated and one a little above the other, relieving on closing the eye. There is no history of any tilting of images. Double vision was present both for distance and near, and it was worse on looking towards the right side. 3 days later, he noticed drooping of the left upper eyelid, which was severe. Double vision was again relieved after the complete closure of the eye. No history of any ocular pain, redness, discharge, or blurring of vision. No history of any diurnal variation of the ptosis. There was no history of any sudden decrease in vision, no protrusion of eyeballs, no history of trauma or head injuries, no history of recent immunizations, no history of headache, nausea, vomiting, no history of loss of consciousness, no history of hearing loss, loss of smell or taste, no history of difficulty in swallowing or speech, no history of any scalp pain while combing the hair or any jaw claudication, no history of any recent weight loss or muscle stiffness or tiredness towards the evenings, no facial or body numbness or no weakness, no history of involuntary movements of the hands or change in gait or associated altered sensorium also. This is a picture of the patient who is having the ptosis and the diplopia, who is purposefully closing his left eye for relieving the diplopia. Coming to the past history, he gives a history of similar episode of complete ptosis in the right eye with diplopia 5 years back and was diagnosed to have some nerve problem in the right eye, which resolved in an year after the medical treatment. He is using glasses in 6 years for both distance and near and using present glass for the past 2 years. No history of any eye disease or surgeries in the past, no history of eye trauma or head injury or fall from height in the past. Coming to the medical history, he gives history of diabetes mellitus since 20 years on OHA, which he stopped since 1 year, and the current diabetic status is not known, and the last visit to the physician was 1 year back. History of cardiac bypass surgery 4 years back, and he is on anticoagulants. No history of hypertension, dyslipidemia, or tuberculosis. No history of any other surgeries or injections in the eye. Family history, there is no relevant family history. Coming to personal history, his sleep and appetite is normal. Bowel and bladder habits normal. He's a chronic smoker. Since 10 years, he smokes 1 packet of cigarette daily. There are no other addictions. Coming to general physical system examination, he's well built and nourished, well oriented, no pallor icterus, cyanosis, clubbing, lymphadenopathy, edema. Head posture is normal, no facial asymmetry except for the left side ptosis, no proptosis or no nystagmus. Coming to the vitals, the vitals were normal except for the blood pressure. It was 220 by 110 millimeters of mercury in the right upper limb in sitting position. He was afebrile. Coming to CNS examination, his higher mental functions was normal. He was conscious oriented in time, place, and person. His intelligence and speech was normal. Coming to cranial nerves, the cranial nerves was normal. I'm not detailing it. Coming to the olfactory nerve, it was normal. Optic nerve was also normal. The third nerve will be discussing later. The fourth and sixth nerve was also normal. The fifth nerve, the sensory, the motor, the reflexes were also normal. The seventh nerve, the motor and sensory was also normal. Wrinkling of forehead, the closing of the lid, showing the teeth, blowing of the cheeks were all normal. Coming to the eighth nerve, the Rennie's test and Weber's test was normal. The tuning force text all was normal. There was no history of any sensory, there was no sensory neural deafness. 9th and 10th was also normal. There was normal gag reflex and parietal reflex. There was no shrugging of, the shrugging of shoulders was normal. There was, the trunk protrusion was normal. There was no wasting also. Coming to the motor system, the bulk power and the reflexes were normal. It was grade 5 power, both in upper limb and lower limb, and both the superficial deep reflexes were normal in both upper limb and the lower limb. Coming to sensory, the touch sensations, the pain sensations were also normal, and there was no signs of meningeal irritation like neck rigidity or other signs. The musculoskeletal system, the gait was normal. The cerebellar functions were also normal. There was no nystagmus, and there was Romberg's was negative, and he walks in the straight line. Coming to cardiovascular system, respiratory system and GIT, all were normal. The musculoskeletal system, it was normal and there was no abnormal gait. Coming to the ocular examination, the head posture was normal. The facial symmetry is maintained except for the ptosis in the left eye. There was no face turn or chin elevation or head tilt. There was no proptosis. So on passively elevating the left upper eyelid, the left eye was exotropic and hypertropic in the primary gaze. Coming to ptosis evaluation, the palpable fissure height in the left eye was 5 mm, with the marginal reflex distance 1, is minus 1 mm in the left eye. MRD2 was in the left eye was 6 mm. The LPS function on the left eye was 4 mm, which was poor. The fatiguity cognitive which was negative. The ISPAC test is negative, and there was no evidence of any signs of aberrant innervations also. Coming to the versions, on Levo version, there is a limitation. There is a -3 limitation in the left eye. And on Levo depression, there is a -2 restriction, by -2 limitation in the left eye. On the dextro elevation, dextro elevation, there is a -4 limitation in the left eye. And as we can see in the dextro depression, we can see a -3 restriction, but here the intorsion was normal. Mainly, even though there's a restriction, the intorsion was normal because here we are mainly looking for the superior oblique muscle. Then here we can see the levo version is normal. Coming to ductions in the right eye, ductions was normal in the right eye. In the ductions in the left eye, it showed a -3. It showed a limitation of all the movement except abduction and intorsion. Coming to the vergence, it was abnormal. Accommodation was normal. Coming to the Hirschberg test, that is Hirschberg test, it showed a left exotropia 30 degree with a minimal hypotropia, that is it was less than 15 degree on primary gaze, which was on passively elevating the lid. On passively elevating the left upper rail, cover test was done. It showed a left exotropia with hypotropia for both distance and near also. And an alternate cover test was done for both distance and near. It confirmed the findings of the cover test, and a left exotropia with hypotropia was found, and confirming again and showing that the secondary deviation is more than the primary deviation. A prism bar cover test was done. That is primary deviation was checked first. That is with the right eye fixing. It showed a 50 prism diopter base in and a 10 prism diopter base down. That prism was kept on the right eye. Then the secondary deviation with left eye fixing, a 60 prism diopter with base in deviation was there. Confirming the alternate cover test that the secondary deviation is more than the primary deviation. Coming to the force direction test of all the muscles was negative in this patient. Force generation test was also negative for all the muscles. Coming to saccades, it showed a floating saccade zone moving from lateral gaze to the medial gaze. Coming to the visual acuity, his visual acuity was unaided, it was 6/12 and 24 in both eyes. And by both objective and subjective refraction, it showed a compound hypermetropia, and he was improving to 6/9 and N6 in both eyes. Coming to the IOP, it showed it was normal, 17 and 18 in the eyes. The color vision and confrontation was also normal, which was tested on passively elevating the lid. Coming to eyebrows, lids, and lashes, there was severe ptosis. The levator function was poor. There was no lag of ophthalmos. Ocular motility was normal in the left eye. In the right eye. In the left eye, all movements were restricted except for the abduction and intorsion. Conjunctiva in the left eye was normal. There was no congestion. Cornea, it was normal. There was a normal size, shape, and luster. The transparency was there, but the corneal sensations were also normal. Coming to the anterior chamber, it was grade 3 von Herix with an optically empty anterior chamber. The iris was normal in color and pattern. The coming to pupil, it is 2 mm, round, regular, direct, indirect was normal. There was no anisocoria. Coming to the lens, he showed a grade 2 nucleus sclerosis with a cortical cataract. Coming to the fundus, the media was clear. Coming to the media was clear. The disc was normal in size, shape, and color. No disc edema, atrophy. Margins were well defined. CDR ratio is 0.4. NRR is healthy. Vessels of the disc normal. AV ratio is 2:3. Periphery and macula is normal. Coming to special test, it is a diplopia charting. Diplopia charting was done by a red-green glass was given to the patient. Red on the right eye, green in the left eye, and the images were being separated, seen as separated more towards the right gaze and also in the up gaze. Coming to Worthford test, again red-green glasses were given. It showed a cross diplopia. So coming to summary, it is a 73-year-old man, non-case of diabetic, uncontrolled on OHA, chronic smoker with complaints of double vision for 7 days duration, and drooping of the left upper eyelid for 3 days duration. On examination, in general system examination was normal. BP was recorded as 220/110. His VCV is 6/9 and 6 in both eyes. There is limitation of all movements in left eye except intorsion and abduction. Pupillary reaction is normal in both eyes. Anterior segment examination showed grade 2 nucleus sclerosis with cortical cataract in both eyes. Fundus was within normal limits. Provisional diagnosis, isolated pupil sparing partial oculomotor palsy in the left eye, probably due to microvascular ischemia, probably due to uncontrolled diabetes and hypertension, severe ptosis with poor LPS function, immature senile cataract both eyes, with a compound hypermetropic astigmatism against the rule in both eyes. Thank you, sir.
Thank you, Dr. Leia. Can you stop sharing your presentation?
Dr. Leia, that was a super first presentation. Okay. Any other, see, from your presentations, there were one glaring mistake which I saw. Can you just try to recollect and see and tell me what mistake you have made in the presentation? Any other postgraduates were sitting there, the other 6 can also tell. You go to the last slide, the diagnosis slide, and try to see the findings, whether there is any mistake there. That is one thing. Second thing is, when you saw the fundus of the patient, what were you looking for in this case? Dr. Lara, no?
Sir, in fundus, basically we have to see the macula is normal or not.
No, in this particular patient, what all things you see, you know the history, you know the presentation, what all things you saw in the fundus, you try to see in this case.
We have to rule out a space occupying lesion. So raised intracranial tension has to be ruled out. So we must see for a papilledema is there or not. The disc margin.
So in this case, what did you think first? All the facts are there in front of you. All the things, whatever I'm asking you is based upon the findings which you have presented to us. What you should look for first. You written everything is normal, but I'm just asking you. See, patient has a pressure, blood pressure of around 220 or 110 or something you told. So first thing is you should rule out whether the patient has got hypertensive retinopathy. Okay, that is almost going towards a malignant hypertension, whatever BP you have presented there. That is one thing. The last slide in your diagnosis, you have made, I think, what type of ptosis there? This slide, you told the patient has got ptosis.
Ptosis is the poor LPS function.
What type? You have written severe, no? Why you have written severe ptosis? How do you grade ptosis?
When we grade it,
these are the mistakes. See, basics you should know properly. How do you grade ptosis? Mild, moderate, severe.
Mild, moderate,
severe. What is mild ptosis?
Mild ptosis, if the ptosis is around 2 mm, moderate it is.
What should be 2 mm?
Sir?
What is 2 mm?
So if it is a unilateral.
What is 2 mm? What is the 2 mm?
It is covering the cornea.
That is your MRD one.
Yep.
Huh? What should be 2 mm?
Margin to reflex distance. Sir is asking, what does 2 mm stand for denote?
Mild, moderate, severe. What is given in Kansky, you should tell, ma. I'm not asking you anything out of the book.
What sir is trying to point out here is you've given a diagnosis of a third nerve palsy here, but you also given a diagnosis of ptosis. So that's what he's trying to point out here.
That is one thing.
Are you able to pick out?
Yeah. Degree of ptosis also you have mentioned it.
Yes.
Wrong. Yeah. So 2 to 4, more than 4. You have written severe ptosis, I think, in the diagnosis slide. But what is your MRD1?
MRD1 is -1, sir, but difference in palpebral fissure height is 5 mm.
Okay. So it is a case of severe ptosis only. So what type of ptosis is it?
So it's a severe ptosis.
Your ptosis, how do you classify ptosis?
It can be neurogenic.
It cannot be. You should tell it is a neurogenic ptosis in your case. In this particular case, and whatever we are asking you is pertaining to this particular case only.
It's a neurogenic ptosis.
Neurogenic ptosis. So, okay, that is one thing. Second thing is you tell the patient is having all your clinical findings are pointing out to a case of third nerve palsy. That is what you are telling. What type of third nerve palsy is it?
So it's an isolated third nerve palsy.
Why do you say it is an isolated third nerve palsy?
Isolated third nerve palsy, no other cranial nerves are involved, and it's also a partial third nerve palsy, mainly because there is no complete restriction, and it's a pupillary sparing also.
Pupillary sparing third nerve palsy. That is what is your diagnosis without any other odd neurological signs elsewhere. That is all you have written a musculoskeletal system there somewhere in one of your slide. Yes, instead of that, you can just tell a neurological evaluation, no motor deficits or something, no sensory motor deficits that you can mention. That indicates probably your deep tendon reflexes and other things are normal, grossly normal, that you can mention. Okay. Instead of that musculoskeletal thing, you can just mention that slide. Okay. Okay. So supposing if the patient was not having an isolated third nerve palsy, what were the other things, possibilities you would have thought of? Supposing the patient had some other findings in addition to your third nerve palsy on a neurological evaluation, what are all the other syndromes associated with a third nerve palsy?
So the third nerve palsy, based on the anatomy, the third nerve palsy itself can be localized based upon the nuclear lesion or a fascicular midbrain lesion or a subarachnoid lesion or a cavernous lesion or an orbital lesion. If it is a nuclear lesion, there should be a bilateral ptosis or a contralateral superior rectus restriction should be there. If it is in the vesicular midbrain portion, there are 4 syndromes associated. The first syndrome is a North syndrome. It is associated with ipsilateral third nerve paralysis with an ipsilateral cerebellar ataxia. And the second syndrome is a Claude-Bernard syndrome. It is associated with an ipsilateral third nerve paralysis with a contralateral cerebellar ataxia. And the third one is the Benedict syndrome, in which there is a ipsilateral third nerve paralysis with contralateral involuntary tremors. And the fourth syndrome is the Weber syndrome, in which there is ipsilateral third nerve paralysis with contralateral hemiparesis.
Good. Okay. So in your case, where do...
Sir, can I interrupt, sir?
Yeah, tell me now.
Can I take my charger, because now
Yeah.
Okay. I think that was an excellent answering by her. Yes. Though she seemed a little tense, but it was a very good answering by her thing. And I should really congratulate Gopal for the excellent layout and the plan for this. Yeah.
Postgraduates.
Yes.
Not Gopal. Sorry.
Yeah. For this,
both of you
for this plan of, this is a real interesting plan. Yeah. Yes. Relax, Leia. You're doing fantastically well. And just continuing in the lines of what you were talking. And I think for the benefit of all the other postgraduates who are listening, can you tell us how you would go about localizing the site of lesion in a third nerve palsy? Can you hear us?
Yeah.
Leia, can you hear us? Yeah.
Part of the answer is there in the reply given by the presenter itself.
Yes.
Others can just chip in.
Leia only, you can tell us, Leia, how do you go about localizing a third nerve lesion?
Localizing the third nerve lesion based upon the first is based upon the, if it is a nuclear lesion, there will be a bilateral ptosis will be there. And
let's go the other way around. Let's go from the orbit to the nucleus. That would be much easier for the postgraduates to follow. You're relaxed. You're doing very well. Fantastic answering. I would have fared so badly in a squint case. Squint has always been my weak point. You're doing fantastically well. Let's go the other way around so that the postgraduates understand it more easily. Yes.
If in the orbital part, if in the orbital part actually, there are 2 divisions for the third nerve. There is an upper division and a lower division. The upper division, the third nerve, supplies the levator palparis superioris along the superior rectus, and the third nerve supplies the inferior division supplies the other muscles, including the nerve to inferior oblique is there, and that is supplied in the sphincter pupillae. So if the upper, so usually in orbital part, only one of the divisions will be affected. Then coming to the cavernous part. In the cavernous part, what happens is that there are multiple cranial nerve involvement will be there. Multiple cranial nerve involvement will be there, and also associated. For example, if there is a Tolosa-Hunt syndrome and all, or a superior orbital fissure syndrome, here the optic nerve is also involved. And also in the cavernous sinus, there are other features like cavernous sinus thrombosis and all. There will be fever and all. Then coming to the subarachnoid region. In the subarachnoid region, there will be there can be the most important cause is the aneurysm. The aneurysm is mainly on the posterior communicating artery aneurysm, and here it can be painful also. And others are it can be a base of meningitis. The history will be the fever will be there, and other signs of meningeal signs will be also there. And associated, then there are also causes like granulomatous inflammations like sarcoidosis, Wegener's granulomatosis, and all. Then comes to the fascicular part, fascicular midbrain part. Then in the fascicular midbrain part, what happens is that again there is a if the fascicular midbrain part, as I told, the syndromes are associated with it. Like if it is, and if then that is hemiparesis will be there, or contralateral flapping tremors will be there, or it can be, and in the if it is a nuclear part comes the bilateral part. If there is a bilateral ptosis involvement will be there, mainly because the caudate nucleus is supplying both the levator palparis superioris muscle, and the other one is the superior rectus nucleus. The superior rectus nucleus, it's supplying crossed. So the contralateral superior rectus will be underacting.
What's
So
the
in your particular case, where do you think is the lesion?
So it's a microvascular ischemia is the reason. It can be in the basilar or in the cavernous.
Okay. You told the patient is having a partial third nerve palsy.
Yes, sir.
Okay. Can you just, there are some rules actually in a case of third nerve palsy. Suppose, can you just tell me those rules? Sometimes you can get a partial third nerve lesion with some of the parts of the third nerve, the muscles which are being supplied by the third nerve being involved. But there are certain situations wherein you cannot call it as a partial third nerve palsy if it is an isolated, what? Patient is having a third nerve, some lesion there. Supposing if, I'll just tell you the answer, if the patient is having a medial rectus, isolated medial rectus paralysis or an isolated mydriasis, it is never usually due to a partial third nerve palsy. That is one thing you should remember. So in your case, I agree with you that the lesion is not in the orbit. Do you feel it is in the orbit?
No.
You can get a partial third nerve lesion if it is in the orbit. What are the points to say it is not in the orbit or at the level of the superior orbital fissure in your case?
Sir, if superior orbital fissure was involving, the vision might have been dropped, or the other cranial nerves also have been involved, or in the orbit, it should be an isolated nerve palsies, isolated nerve.
And if it is a space occupying lesion, you can see a little bit of proptosis, extraocular motility disturbance, all those things you can see, proptosis and all those things. Supposing if it is a case of cavernous sinus.
Yes, sir.
I will tell it is in the cavernous sinus. How
would you rule out? Yeah.
So cavernous.
I tell it is a small lesion in the cavernous sinus which doesn't produce your thrombosis, not a severe CVT, what you say, classically see, a small lesion involving the cavernous sinus. Where is the nerve situated in the cavernous sinus?
So the third nerve is situated on the, above all the orbital nerves, and the content
Which is the immediate neighbor of this third nerve in the cavernous sinus?
Just below is the ophthalmic division of the trigeminal nerve.
Anything else?
Along with it, the ophthalmic and maxillary division of trigeminal nerve, and also there is a abducen nerve, and also
where is the fourth nerve?
The third along with fourth nerve, and ophthalmic and maxillary divisions of trigeminal nerve, and along with
How did you check whether the trochlear nerve was involved in this case or not?
For this, we have to, on attempted down gaze, we have to check the intorsion. Keeping in on slit lamp, actually, we can see the nasal, we can have to mark the nasal vessels and the lateral vessels. So we can see the intorsion actually, that is nasal vessels will go down, the lateral vessels will, limbal vessels will go up.
But in your case, you told there is a little bit of partial paresis. It is not a complete paralysis of the third nerve. How did you check?
Actually, sir, in this patient,
sometimes it is very difficult to check, especially if it is a partial paresis. That you should keep in mind. Okay, fourth nerve, the involvement of the fourth nerve. Supposing if it were to be a gross lesion in the cavernous sinus, what will be the clinical feature? Do you think your patient is having a problem in the cavernous sinus? No, because the patient doesn't have any proptosis. Okay, so the other two areas which you told probably the lesions are there is the right answer. I will tell you if the patient is having a nuclear lesion. Do you agree with that?
No, sir.
Why? I think you told the answer already. All the postgraduates see all these things require repeatedly brushing through this knowledge. Third nerve palsy, you should know everything. There are a lot of dictums. You can just make a note of all the points of third nerve palsy. Okay. Next, supposing this is a case of the third nerve palsy. You told it is a case of pupil sparing third nerve palsy. Why do you say it is a pupil sparing third nerve palsy? I will tell probably it is a third nerve palsy, partial third nerve palsy, which is in evolution going to a total third nerve palsy, 1 week duration. Third nerve palsy going in for, you told, ptosis is still evolving. Initially there was diplopia, gradually the diplopia disappeared. Probably it can be even a third nerve palsy in evolution also. Okay, pupil sparing third nerve palsy. Supposing, why do you say it is a pupil sparing third nerve palsy?
So in the initial stages, both the pupillary reflexes were normal, and it can be pupillary sparing. But on the follow-up of the patient, we have to look for the pupillary involvement, because a small aneurysm can enlarge and impinge, causing a pupillary involving. So for that, we have to do a digital subtraction angiography for a smaller aneurysm to see if that smaller aneurysm is impinging or not.
Okay, this aneurysm will impinge the third nerve and produce a pupil affected palsy. What will be the size of the shape of the pupil? What type of pupillary defect you get if there is an involvement of the pupil?
It will be fixed and
pupil sparing is pupil is normal. Pupil is affected, what will be the pupil?
It will be fixed and dilated.
Okay, it is a more of an efferent pupillary defect compared to this thing. Efferent pupillary defect you will be getting. So why do you get efferent pupillary defect in certain conditions? Why you get no pupil being involved in certain conditions? What is the reason?
Sir, actually the pupillary fibers are supplied by the pile plexus, that is very superficial in nerve trunk, and but the pupillary sparing, it is supplied by the vasa nervorum, that is mainly supplying the central part of the nerve trunk.
Good.
And, the pile, so in pupillary involving, it is mainly actually supplying. It is the pile vessels are affected in pupillary involving.
Okay. So in this case, what do you think is the cause of Turner palsy?
So since my patient is an elderly patient who is diabetic, who is uncontrolled, who is a chronic smoker, uncontrolled hypertension is there, and he had a history of third nerve paralysis 5 years back also. So most probably it could be a microvascular ischemic cause.
Okay, otherwise it can be an infarct. It is an infarct secondary to ischemia, which has produced this type of terminal palsy. Good. Madam, you want to ask anything?
What's the implications in trying to differentiate between a pupil sparing and a non-pupil sparing third nerve in the management?
Ma'am, so if it is pupillary sparing, it's mainly of a conservative management with the help of a physician who will control the comorbidities. But in pupillary sparing, if it can be life-threatening also, because if it is an aneurysm, we have to get a help of a neurosurgeon for coiling and clipping and all. So that is the.
Okay, so
supposing the patient you mentioned about meningeal signs, that is one important thing which you mentioned. When do you think a third nerve palsy is an emergency? What condition do you feel whenever you see a third nerve palsy with plus presentations? You should refer the case to a neurosurgeon immediately. What are those plus things?
If it is a pupillary involving, and then
patient will be having.
If associated hemiparesis is there, and
more than that, severe headache the patient will be having, sudden onset,
acute onset
of headache. Third, meningeal signs. If you see any meningeal signs, it is a emergency. That you should refer the case to a neurosurgeon. Excellent.
So those are the implications. It helps you to decide between a surgical intervention and a medical management, a pupil sparing and non-pupil sparing. So when you see an acute onset, a pupil involvement here, then you would suspect an intracranial involvement. It could be a meningitis, a space-occupying lesion. There could be other neurological causes here. So that's the grave implication in when you're looking at a pupillary involvement and acute onset, and as sir rightly pointed out, the other grave neurological associations here. So that's important in recognizing as a postgraduate or a resident or as a treating ophthalmic surgeon, that you know when you to send the case, because that could be really life-sparing for the patient here. Yes, I think that's a fantastic discussion here. Gopal, do we need to move on?
Yeah.
Thanks so much, Leia. I think it was a very wonderfully presented and discussed case.
Yeah. Akila will now present. Akila.
Good morning, everyone. I'm Akila, doing my post-graduation in Computer Institute of Sciences. My case is about a 55-year-old female who is a housewife by profession from Maldives. She presented with a chief complaint of sudden decrease in vision in the right eye since morning with severe pain. This symptom was preceded by redness with pain and watering and difficulty in looking at light in the right eye, which has been there for past 2 weeks. My patient was apparently normal 2 weeks back when she noticed redness in the right eye. Initially, she ignored the redness. After 3 days of the initial presentation, she developed watering, foreign body sensation, and photophobia. Slowly, she started experiencing pain and photophobia increased in intensity. She noticed blurring of vision in the same eye, and then she consulted an ophthalmologist for the same and was diagnosed to have a corneal pathology and was started on topical medications. She was on treatment for the same, and she noticed sudden decrease in vision with severe pain since the presenting day morning, following injury to the right eye with her own finger. There was no history of any foreign body falling in the eye, no history of dryness of eyes or irritation, no history of contact lens wear prior to the first symptom, no history of difficulty in eye closure, no history of stroke or any other recent surgeries, no history of usage of any eye drops previously, no history of diabetes or other autoimmune disorders. There is no history of similar complaints in the other eye also. So coming to the ocular history, 2 weeks back, she had consulted an ophthalmologist with the chief complaint of pain, redness, and watering and photophobia. She was diagnosed to have a corneal ulcer and corneal scraping was done and microbial keratitis panel was sent. No organism was identified on gram smear and Cohead smear. In culture also, no organism grew after 7 days of incubation. So she was started on natamycin, Zymaxid, atropine, and systemic antifungal, that is ketoconazole. And she was on that medication, after which she presented with sudden decrease in vision. Past medical history, she is a hypertensive since 4 years and is on medication. There is no significant drug history or any family history. On examination, general examination is completely normal. Systemic examination is normal. Ocular examination, ocular normal head posture, alignment appears orthotropic, facial symmetry is there. On examination, on local examination, the right eye vision is perception of light is present, projection of rays is accurate. Intraocular pressure, we could not assess by any other means, so we assessed by digitally. So it appeared on the, it was on the lower side. In the left eye, the vision was 6.9, improving to 6.6 with a near vision of N6 with +2 addition. And intraocular pressures by non-contact tonometry was 16 millimeters of mercury. Extraocular movements were full in all cases in both eyes. There was no pain on extraocular movements. Moving on to the anterior segment examination, in the right eye, the upper lid was covering 4 millimeters of the cornea. There was blepharoplasy. Lid margin was edematous. Meibomian gland orifices are open, but there was no fluid expressing out. Skin over the lid is normal. Eyelashes normal in size, color, position, but they were matted. Lacrimal apparatus, puncta is visible. There is no swelling in the lacrimal sac area or any tenderness. Rhoplast test was negative. Conjunctiva showed moderate circumcorneal congestion with congested upper and lower palpebral conjunctiva. There is no discharge. In the left eye, everything was normal. Moving on to the cornea examination, in the right eye, on diffuse illumination, cornea is irregular in surface. There is complete loss of normal corneal transparency and luster. Centrally, there is a large area of infiltration, which is irregular in shape, grayish white in color, full thickness, and is covering almost 2/3 of the cornea, which is surrounded by stromal edema. The stromal edema is more intense inferiorly. Peripheral part of the infiltrate shows overhanging edges with tissue necrosis. Peripherally, there is a large corneal perforation measuring about 5 into 2 millimeters, extending from 1 o'clock to 5:30 o'clock position, with iris incarcerated at the area of perforation. In periphery, the infiltrate is associated with superficial vascularization from 12 o'clock position to 7 o'clock position, more prominent from 1 o'clock to 3 o'clock position. Corneal sensations could not be assessed. The Siedel's test was positive. Left eye was within normal limits. This is my corneal diagram. On frontal view, we can see diffuse infiltrate with a corneal perforation and incarcerated iris. There is diffuse stromal edema, more intense inferiorly, with a superficial corneal vascularization and minimal scarring inferiorly. This is the slit view of the same. Here we can see this border, there is overhanging edges are there with tissue necrosis. You can see the stromal edema and the irregular shaped infiltrate. On slit lamp examination, we can see the perforation extending from 1 o'clock to 5:30 o'clock position with the incarcerated iris tissue. There is a large infiltrate, which is about 18 to 6 millimeters. Corneal vascularization from 12 o'clock to 7 o'clock position. And inferiorly, there was minimal scarring along with corneal edema, stromal edema. Anterior segment examination, in the right eye, the anterior chamber was completely flat. The iris was incarcerated at the level of along the perforation. Just inferotemporally, minimal amount of iris was visible and it appeared to be normal. Pupil, it was irregular pupil and other details of the pupils could not be assessed. Lens and anterior 1/3 of the vitreous details could not be assessed. Left eye was normal. Pupils were 2.5 millimeters. Direct reflex was there, and consensual is also there. Lens, early lens changes are just present, and anterior 1/3 of the vitreous is optically empty. Dilated fundus examination, right eye, there was no view, so I did a B scan, which was normal. In the left eye, media was clear, disc and macula were normal, vessels and periphery were also normal. To summarize, my case is a 55-year-old female who is a known hypertensive, presented with a chief complaint of sudden painful decrease of vision since one day, which was preceded by complaints of redness, watering, and photophobia. After my history and clinical examination, I am giving a probable diagnosis of right eye corneal ulcer with corneal perforation and systemic hypertension.
So,
Thank you, Akila. Yeah.
Dr. Akila, they keep a corneal ulcer as a long case there, sir? Dr. Gopal?
Not necessarily. I actually asked them to have a corneal opacity with, which is basically post-perforation. But I think she took this, and once she was ready, then this is a virtual exam. You can have a discussion on this. Usually it is not kept. Yes.
Okay. Usually we keep it as a short case here, madam. Vanati, madam, there at AIMS, madam.
We do have keratitis also, but not perforated keratitis usually, because they are acute patients here. So something which is healing, and commonly you would probably have a fungal keratitis here, just because we wouldn't want to, put the patient into a lot of inconvenience, basically. But yes, very well presented, Akila. So here you have a patient of a perforated corneal ulcer, which you are seeing here. So how would you differentiate, or let's look at it in two ways. What's your etiological diagnosis here? What's your morphological diagnosis?
Etiologically, it's looking like a corneal ulcer, perforation post keratitis, ma'am. As on my examination, I could see some ulcer border with overhanging edges, which is a sign for, and the ulceration was in the periphery also. So, which is giving an origin of inflammatory or autoimmune kind of keratitis also. But there is severe infiltrate and severe stromal infiltrate, which is much pointing towards the infective side. So etiologically, it can be infective or inflammatory, ma'am. I need to further examine, do corneal scraping, repeat corneal scraping and immunological examination to confirm my etiological diagnosis. And functionally, she is giving a history of trauma, post which sudden decrease in vision has developed. But usually corneal perforations happen only if there is trauma with high velocity projectiles or some hooks, which is just an injury with the finger. So it can be due to the trauma, or the corneal ulcer also might have perforated, ma'am.
So yes, as you said, from what you could see from the pictures is a large circumferential ulcer lying at the periphery with also central corneal involvement here, and you have a large area of the iris plugging the inflammation, and the lids did not look healthy as well. So it could be both an inflammatory, a local inflammatory, or an autoimmune condition. And so it probably looks like a peripheral ulcerative keratitis, which has perforated here, and it could be a secondary bacterial infection or a secondary infection, which has sort of spread and also added on to the acuteness of the lesion here. So it's very, from what you presented from your pictures, it's not looking very clear cut. But yes, I would put it in as a peripheral ulcerative keratitis with a perforation here. So if you would go ahead on the lines of a PUK, before that, how would you differentiate a bacterial and a fungal keratitis?
Ma'am, a bacterial keratitis will present with sudden onset, ma'am. Symptoms precede signs, ma'am. There will be severe congestion with pain, ma'am. The ulcer edges are sharply demarcated, ma'am. We'll have a sterile hypopyon, which is mobile. And along with that, severe stromal infiltration also will be there. If it is a fungal keratitis, ma'am, it will progress towards, during a period of 1 to 2 weeks, symptoms will gradually progress. The congestion is a bit less compared to that of bacterial keratitis. We have dry ulcerated borders with feathery margins, ma'am. And we have an unsterile hypopyon. mostly following injury by vegetative matter, ma'am. We have an unsterile hypopyon, which is thick and whitish in color with a convex top, and which is immobile, ma'am.
Okay.
Satellite lesions can also be present with the fungal
Absolutely.
keratitis, ma'am.
Yes.
Dr.
So you
Akila,
do have an acute. Yes, Dr. Nagaraj.
Dr. Akila, in your diagram, whatever you have written, no, next time when you write a diagram, that diffuse picture, whatever view you have written is okay. But in the cross section, no, what you should mention it, you should mention this diagram at different layers. You can make some marks on the frontal diagram, at least 3 areas: the area where there is a stromal edema, the area where it is apparently normal, and the area at the type of site of perforation. You should take a cross section and you should write 3 diagrams there. That will give the complete picture of the this thing. And your description of the ulcer is not accurate actually. You just told vaguely it is a 2/3 of the cornea and all those things. So basically, whenever you describe a corneal lesion, you describe the cornea first. Second is you describe the lesion in the cornea. Then it will be easy for you. Whenever you examine a cornea case, you forget all the pathology there. Try to concentrate only on the cornea. You mention all the cornea. When you examine the cornea, when you mention the cornea, you should mention the precorneal tear film also, the lids and adnexa also. So likewise, in the other eye, you should mention about the tear meniscus, all those things. So like Madam said, if it is, this is a case of PUK, you should think about dry eye and other conditions which are associated with that. And you should mention about the tear meniscus and other things. For that, even in the diagram itself, you can make a representation. In the cross section, whatever you have depicted there are no lids seen at all. Initially, I thought those two things are the lids. Actually, that is the cornea. And you have written this stroma, no? How do you document a stromal haze, stromal edema?
It's blue color, sir.
Blue color. Okay, you've done that properly. And hatching, when will you do? All those things you should learn, how to depict a corneal lesion properly. And you are not mentioned the lids there. The lids have to be mentioned there with the eyelashes, and you should mention the tear film also. How do you depict a tear meniscus in a profile? See, when you write a diagram, a diagrammatical representation, no, what you should do, the lower lid margin, you can just mention a tear meniscus there. Supposing if it is an isolated isosceles triangle, it is a normal tear film. Supposing if there is a dry eye seen there, the hypotenuse, you can make it as a concave thing. And you can put some small marks there to indicate if there is a debris there. So that you can depict there itself in the, that will give a better impression to the examiner that you examined very well. So you make diagrams at 3 different levels, 3 different areas, and you can think. See, the other differential diagnosis, I think, is still you can keep in mind keratomycosis in this case. Supposing if this systemic examination rules out all the connective tissue disorders and other things, you are left with only a Moran's ulcer and you are left with an infective condition. Patient, an elderly lady with an apparent innocuous trauma or no trauma, and 3 weeks duration, the patient has not used any medication and the patient has come to you, you can still keep in mind a keratomycosis in this condition also. Since there is a total almost a perforation there, probably you cannot see an hypopyon there in that particular area because of the extensive edema. Probably there is a small hypopyon. So these are the 2 things. And whenever you see such a large perforation, I would hesitate to do a digital tension. I think somewhere you mentioned the intraocular pressure is low or something. No?
Usually we do it with 2 fingers, sir. When
No, that is digital tonometer only. Huh? One is your indenting finger.
And once it's perforated, you should not mention a digital tonometry because you're going to augment the morbidity of the condition. Yes. So that's something, and as sir rightly pointed out, several postgraduates do forget that in a corneal ulcer, you jump directly onto describing the cornea. You should remember several corneal conditions are pre-led onto the adnexial conditions. It's not only, adnexia does not mean only the sac system here. So adnexia means the lid margin, the precorneal tear film. It means your meibomian glands here, the health of how your lashes are positioned, your lid margins are positioned, and your pre-existing dry eye conditions here. So a lot of things, and from what you presented, it's very difficult to say whether I'm looking at a PUK, if I'm looking at a keratoconjunctivitis, whether it's an immune condition like a Moran's, or if there are other systemic vasculitic conditions which have caused an immune keratitis, or it could be simply a case of infectious keratitis. which has caused a circumferential melt. It could be because of fungus, it could be because of virus as well, because you have a delayed history. And if you see, there's not much of vessels which is grown in, and there is a perforation which is about circumferential. So it's a little inadequate from the history you're giving, not a very clear-cut textbook kind of a picture for an exam. But since you have taken it, I think it is we could discuss all these points if you have such a case in the examination. Usually you do not have perforated ulcers which are sitting there out here. So if you just look at it as a case of, say, infectious keratitis, as sir pointed out, let's assume it's a fungal keratitis. What would be your next course of action in the management of this case?
Ma'am, I want to start an antifungal eye drops, ma'am, natamycin, 5%, ma'am. I would like to start
So if it's not a perforated ulcer, you would go ahead and right away start an antifungal treatment?
Ma'am,
Is there, what investigations would you prefer to do in these patients?
I will do a corneal scraping, ma'am, and I will send it for gram smear, KOH smear, culture, bacterial culture, as well as fungal culture, ma'am. And while I'm awaiting the reports, ma'am, I will start on empirical treatment both for bacterial and fungal, ma'am, so that we can cover gram-positive bacteria, gram-negative bacteria, and fungus as well. As soon as I isolate any organism, then I will focus my treatment on fungi or bacteria, ma'am. If I am suspecting a fungal, clinically, if it's looking like more fungal, then I will start with natamycin, ma'am, giving a loading dose, and then hourly drops, ma'am. And if there is severe corneal thinning, I would like to start ketoconazole along with tetracyclines also.
Okay. So one thing here which you would like to do is just do a simple smear. And from where would you take a corneal scraping in these patients? What's the ideal site for corneal scraping in these conditions?
The margins of the ulcer, ma'am, where the infiltrate is there, along with the base, where
you would always identify the leading edge of the ulcer, remove the necrotic debris, and always avoid regions of thinning for the danger of causing a perforation. And the simple way is to put it under the slit lamp, under your microscope, and examine and look for fungal hyphae. So when you definitely in most of your conditions will be able to pick up a hyphae here. And if you don't, then you would put in an empirical management depending upon how severe the lesion is. One other investigation you would like to do in corneal ulcers. So you're not able to visualize the posterior segment in these cases. You said it's a large ulcer. It's about, say, 7 or 6 into 7 is what I think you said. So what would you like to look at? Do you want to see if there's associated endophthalmitis, posterior spread?
I will check for concentric reflex, ma'am, in the other eye, starting, okay. Then I'll go for a B scan, ma'am.
Usually it's very difficult because a perforated ulcer, you think a perforated, your examination might not be very reliable on this, but yes, you would. One other investigation, you would like to look at the ultrasound of the posterior segment in these cases as well. Because these are cases which are, if it's perforated, you're going to take it for surgery. So which means you're going to have to rule out the extent of infection which is present in these particular cases here. So what is the common antibacterial therapy which is used in infectious keratitis?
Ma'am, if it is a gram-positive bacteria, ma'am, we will start with cefazolin 5%, ma'am, or we can give moxifloxacin or getafloxacin, ma'am. Monotherapy is not advised because nowadays there is high resistance to fluoroquinolone. So I'll go for
that the reason? Is monotherapy indicated or not indicated?
Monotherapy is not indicated, ma'am.
Not indicated. You could do monotherapies in cases where patients are from regions where they do not access formulated, where you cannot make fortified antibiotics. And if the lesion is severe, is mild or moderate, is less than 2 or 2 to 5, and it's off the central axis, and it is responding to your medications, then you could use, if you do not have, all of them do not have access to fortified antibiotics out here. So that is one scenario where you could use, and you probably don't need to use fortified in these scenarios here. What else would you like to do in a case of, how would you differentiate, let's say if you're looking at a PUK, how would you differentiate whether this is a Moran's or this is because of other inflammatory conditions?
Ma'am, Moran's ulcer, there is a very disproportionate pain to the amount of ulcer which is there, ma'am. Mm-hmm. And Moran's ulcer, it's usually present at the site of the limbus, whereas in PUK, corneal ulcer will be around 2 to 3 millimeters from the limbus.
What other involvement do you have to check in your examination? when you look at a peripheral ulcerative keratitis to pinpoint on your diagnosis?
What is that
Ma'am, other
Watson's criteria?
autoimmune disorders.
Watson's criteria. I think madam is
Sir,
asking directly that.
Watson's criteria is for diagnosis of the Moran's ulcer, sir. It has presence of
The
a
answer to madam's question is in that criteria.
undermining edges of the ulcer and with crescent-shaped peripheral corneal ulcer, along with absence of scleritis and detectable systemic disease will not be there in Moran's. It is idiopathic. Whereas in PUK, we have an autoimmune disorder which can be identified by immunological evaluation.
Adjoining scleral involvement is something which you always have to examine in cases of peripheral ulcerative keratitis. And again, look at the lid margins. Adjoining meibomian gland diseases, so when pre-existing conditions of keratoconjunctivitis will all be telltale signs if you're looking at a blepharokeratoconjunctivitis, which leads to a peripheral ulcerative keratitis. And these can have rapid perforations because they are immune abscesses situated in the cornea. And usually the patients present late at the time of a periphery. So that's a important differentials you would like to have in these patients. Yes, Dr. Nagaraj, you would like to take it on?
Yeah. See, one more important thing which I would like to tell over a period of many years experience. I think you mentioned only about Roplast test here. Doctor, I forgot your name. Have you done syringing in
Akila.
this?
No, sir.
Dr. Akila?
I didn't do syringing.
I think it is advisable to do syringing in all cases of infectious keratitis, because most of the time we cannot just rely on a Roplast test. So you always, your prognosis will be better if you do a syringing, and if there is any block in the lacrimal excretory system, and if you tackle it, then the ulcer will respond much better actually. Okay?
Yes, sir.
Yeah, now in this particular case, so we'll presume it is two things. One thing is we'll presume this is a case of peripheral ulcerative keratitis with a secondary bacterial infection. That is one diagnosis. Second is a keratomycosis with a secondary bacterial infection. The patients have ended up like this. Supposing if it is a case of PUK with a secondary bacterial infection with a perforated ulcer, what is your management?
Sir, initially
you told you have controlled the infection. Infection part you have controlled. Both these scenarios you have controlled the infection. Here you have given antibacterial medications. There you have given antifungal, probably an antibacterial to cover up any secondary bacterial infection. So what is the next stage?
Sir, if I'm suspecting PUK, sir, after giving antibiotics for about 48 hours, then I will plan on starting steroids, sir, for a patient with PUK.
No, you will control the infection first. Okay, we will control the infection first. Then you will try to see whether what are the points to say that the infection is being under control. What are all the things you see in the cornea?
Yes, sir. The intensity of the stromal infiltrate and size of the infiltrate will reduce, sir. The anterior chamber reaction will reduce. There will be drainage of hypopion, sir. We'll have vascularization, which is suggesting signs of healing, sir. And there will be re-epithelialization, sir.
Before you start on any topical steroids, can you think of doing something locally if it is a case of Moran's ulcer?
Sir, we
local
can
procedure?
Conjunctival flap resection.
We don't want to do a flap. What is it? What is it? Not flap resection. What is it called as? Peritomy.
A peritomy.
How much of you told it is somewhere between 2 o'clock to 1 o'clock to 5 o'clock. I think that was the perforation you told, no? Yes. Supposing that is the area where there is an overhanging edge, you told in a Moran's ulcer, the ulcer will not be so big. That is what I think in one of the statement you made. But an ulcer, a Moran's ulcer is always deceptive. There will be an overhanging edge which will be covering the ulcer. So you just have to lift the edge to see the large ulcer there. So it will be a very big, huge ulcer also. Supposing you want to do a peritomy, if the ulcer or that PUK is only between 1 o'clock to 5 o'clock position, how many clock hours on either side do you go to do a peritomy? Conjunctival resection.
Sir, at least 2 clock hours more than the perforation
2 to 3
side.
clock hours more on either side, you have to do a peritomy. Then probably once you feel the infection is under control, you start the patient on
steroids.
Topical, which I feel is very difficult in this case. It will take some time, and systemic medication. Supposing if it is a case of an infectious keratitis, which I feel is more likely in this case, a keratomycosis. And what is the goal of treatment of an infectious keratitis? Patient has infectious keratitis. Patient has come to you. What is the goal of treatment?
Sir, we have to reduce the, we have to reduce the pathogenic load, sir. If we are suspecting a fungus, sir, it has a character.
You are not answering my question. What is the goal of treatment of an infectious keratitis? Patient is
the spread to the surrounding ocular structures, sir.
Okay. So one is preventing complications. See, the two main aim of goal of treatment of an infectious keratitis is elimination of infection first. Second is prevention of complications. So nowhere it is mentioned that it is restoration of vision. So you're not going to think about vision whenever handling a case of infectious keratitis. The prime thing is you should try to think of all the strategies to remove the infection. Second is preventing the further complications. Like one is your further spread. Here in this case, already the spread has occurred. There is a very large perforation. There is an iris knuckle which is plugging that large perforation. And what is the almost, you told it is around 5 millimeter to by 2 or 3 millimeter width or something, I think you told. So such a large perforation, how are you going to manage that?
Sir, the management of perforation depends upon the size, sir. If it is less
case
than
you don't forget only this case you tell.
Yes, sir.
Is there any way by which you can put a glue in this case? Can you put a glue in
ideally, sir, ideally we have to go for a penetrating keratoplasty, sir, but the patient is having active infection with heavy stromal infiltrate. So we cannot do a penetrating keratoplasty now, sir. We have to reduce the, thinking it's an infective thing, we have to reduce the infection and then only we can go for keratoplasty, sir. So before that, we can put a glue with a BCL support, sir.
I don't think glue is advisable when there is a large perforation in this case. I think you control the infection, you try to start the patient on systemic antifungals, systemic antibiotics. Topically, anyway, you have started. And as early as possible, I think you should take the case for a therapeutic keratoplasty. That is my opinion in this case. Supposing if it is a case of PUK, the treatment, once the infection controls, you manage it on the lines of PUK, that is Murans and non-Murans. There are two different types of management that you should manage. Okay, so it is more of a therapeutic keratoplasty, which you have to plan. Okay?
Yes.
Okay, ma'am. Madam, you want to add anything?
Yeah, I think that that's a fantastic discussion here. And when you talk about surgical management, I think what sir was asking was what are the indications for application of glue in infectious keratitis? And that's when the perforations are lesser than 2 millimeters. So when you have a large circumferential, you cannot apply glue. And when its iris is protruding outside, glue is definitely contraindicated. You would not want the glue to get in touch with your uveal tissue. And again, what you're doing will be not an optical penetrating keratoplasty, but a therapeutic penetrating keratoplasty is definitely indicated in a scenario which is already perforated and has to be done under general anesthesia. So that's one of the management indications for an intervention here. So just one question before we close. Suppose this is not perforated, there is an impending perforation and it's a thinning, and you're following up this patient. What one investigation would you like to do? It's a recent modality. You would like to do anterior segment OCTs because these are all asked for postgraduate exam. They do ask for applications for recent developments in investigations in pertaining to your case. So you would probably like to do an serial anterior segment OCT to look at corneal thinning, which would help you to decide on whether you would like to take in for a earlier management. If I am finding a progressive thinning on an ASOCT, I would like to take it up before there is an obvious perforation in this case. So likewise, you do have your posterior segment cases. A lot of questions on OCTA implications. OCT implications are currently asked when you're looking at advances in pertaining to your particular presentation cases. So that's something you would all need to go up and brush yourselves upon or make yourself knowledgeable on. And I think if we are lagging, we
can move to the next phase.
Yes.
Yeah, we can move.
Thanks so much, Akila. Yes.
Thank you, ma'am.
Dr. Vikram. Akila, well done. Let's move to Vikram.
Good morning, everyone.
Good morning. Dr. Gopal, will you join us as an examiner in this case?
No, this is not a retinal detachment, sir.
The
In
last one
case,
is.
maybe I can join.
This is not RD. Okay, okay.
A 49-year-old male coming from Kannur came with presenting complaint of redness, pain in the right eye for the past 1 week, and complaint of blurring of vision in the right eye for the past 1 week. History of presenting illness: patient was apparently normal 1 week back. On one day, he had a complaint of redness in the right eye, which was sudden in onset, constant, associated with watering, pain, photophobia. There's no aggravating relieving factor. Patient had similar illness in the right eye every 6 months for the past 5 years, for which he had consulted nearby hospital and got treated. Complaints of blurring of vision in the right eye, which was gradual in onset, constant, and no aggravating relieving factor. No history of pain and eye movement. No history of discharge, flashes, or floaters. No history of fever, headache, rashes, joint pain. No history of any drug intake. No history of any headache, vomiting, or no history of any double vision. No history of any injury. Past ocular history. History of similar illness with a complaint of redness in the right eye for every 6 months, once for past 5 years, which got resolved with medications. Patient was diagnosed to have some swelling in the right eye in the last year, for which he got resolved with IV antibiotics. History of using glasses since 12 years of age, and history of LASIK surgery done in the right eye for 25 years back. No history of any ocular injury, no history of any contact lens use, no history of any chronic medications. Past medical history is a known case of diabetic and hypertensive for the past 18 years, and known case of ischemic heart disease under treatment for the past 2 years. No history of any thyroid, tuberculosis, seizures, asthma, or any systemic illness. No history of any surgeries in the past. Personal history: sleep and appetite is normal. Normal bladder bowel habits, no addiction. Family history: no significant primary history noted. And general examination: patient was conscious, oriented, moderately built and nourished. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema. Pulse 84 per minute and BP 130 per 80 in the right arm sitting posture. Central nervous examination: conscious, oriented, but higher mental function within normal. Sensory motor system were normal. Cranial examination: the olfactory nerve, smell sensation normal. Second, third, fourth, and the sixth will be dealt later. Trigeminal sensation over the face and cornea was normal. Facial nerve, vestibulocochlear nerve, glossopharyngeal nerve, spinal nerve, glossopharyngeal nerve were within the normal limits. Series examination, respiratory examination, periabdominal examination were within the normal limit. Ocular examination: head posture, slightly chin-up position, ocular position, mild pseudo proptosis in the right eye, with Hertel score of right eye 21 and left eye 20, with a baseline of 108. And Hitzberg's test shows left exotropia by 15 degrees, and right hypotropia is there. And cover uncover test shows the left exotropia and right hypotropia is there. Extraocular movements in the right eye, there is a limitation in the abduction, elevation, and mild adduction also. In the left eye, the movements were full. Field of vision by confrontation method, both eyes normal, and color vision were within the normal limits. Assessment of visual assessment: the right eye unaided visual acuity is 1/60, and with pinhole improving to 636, with near vision N36. With retinoscopy, it shows a dull glow of -12 diopters per sphere and -1 cylinders at 130. And acceptance was -12 diopter cylinders with -1 cylinders with 130 and improving to 636, with +2 diopter improving to N36. The left eye, the vision was 1/60 with pinhole improving to 636, and near vision was N10. Retinoscopy showed a dull glow of with -21 diopter sphere, and acceptance was -21 diopter sphere and 6/12, and +2 diopter sphere. Near vision out of N10. Anti-segment examination of the right eye, lid and lacrimal show there is a periorbital edema. Superior fullness is noted. No palpable mass, tenderness, compressibility, thrill noted. Conjunctiva shows a circumciliary congestion, and cornea was clear. Normal luster is maintained. Fine capies and few iris pigment in the back of the cornea, and sensation was the normal limit. Sclera was normal. The anterior chamber is normal depth, and cells 2+ and flash 1+ was there. The iris color pattern were normal. Pupil 2 mm. Regular and sluggish reacting to light. Lens shows grade 1 nucleus fluorosis and posterior subcapsular cataract with that. And intraocular pressure by Goldman ablation tonometry is 12 millimeter of mercury. This is a picture showing the circumciliary condition is there, and a few capies the back of the cornea is noted, and cells flash at that. So left eye. Fundus examination of the right eye show media hazy with this. Fundus examination of the right eye with a distant direct ophthalmoscopy show media haze and dull red close present. Indirect examination of fundus with indirect ophthalmoscopy with 20D lens and with slit lamp biomicroscopy with 78D lens showed disc is large in shape and size. Disc pallor is noted and extensive peripapillary atrophy is noted with the chorioretinal atrophic patches noted around the disc, and macular foveal reflex was dull and the peripheries were within the normal and gross tessellated fundus is noted. Anterior segment examination of the left eye, lid and lacrimal is normal, conjunctiva is normal, cornea is clear and normal luster is maintained, sensation is normal, sclera is normal, anterior chamber depth normal, normal depth and quiet, iris color pattern normal, pupil 3 mm, brisk and briskly reacting to light. Lens show a posterior subcapsular cataract and the intraocular pressure by Goldman ablation tonometry is 16 mm of mercury. And the fundus examination with of left eye with distant direct ophthalmoscopy shows media mild hazy, dull red glow is present, and indirect ophthalmoscopy with 20D lens shows the slit lamp and with slit lamp biomicroscopy with 78D lens showed disc large in size and shape. Disc pallor is noted, extensive peripapillary atrophy with chorioretinal patch around the disc and vessels are normally a branching dichotomicity with AV ratio of 2:3. Foveal macular foveal effects was dull and glossary tessellated fundus and peripheries are normal. The summary, a 49-year-old male who is a known case of diabetes and hypertension, ischemic heart disease under treatment, who had undergone right eye LASIK 25 years back, came with a complaint of redness, pain, blurring of vision in the past 1 week. History of similar illness in the past, every 6 months once for the past 5 years, which resolves on medication. His back test showed left exotropia with 15 degrees and right hypotropia. Cover alternate cover test also shows the same left exotropia with the right hypotropia. Extraocular movements in the right eye show a limitation in the elevation, abduction, and mild adduction. With normal depression is noted. And right eye showed a pseudoprotosis with a Hertel score of right eye 21 and the left eye 20 with baseline 108. Best corrected examination of on examination, best corrected visual acuity in the right eye was 636 in 36 and left eye 636 by in 10. Anterior segment examination, the right eye show a periorbital fullness superiorly and the circumciliary congestion is noted, fine KPs and anterior chamber showed cells 2+ and flash 1+. Pupil was 2 mm, sluggishly reacting and cataractous lens. Left eye shows early cataract changes. And the fundus examination showed both eye media mild hazy, large disc pallor and extensive peripapillary atrophy with chorioretinal atrophy around the disc. Macular FR and cross tessellated fundus noted. My provisional diagnosis, both eyes immature senile cataract, both eye high myopia, and right eye status post LASIK, and right eye acute non-granulomatous anterior uveitis, most probably due to an immunological or autoimmune systemic causes.
Dr. Vikram.
You can stop sharing, Vikram. Sir,
Dr.
please go
Vikram.
ahead. Yeah.
Yeah. Can you hear me?
Yes, sir.
Yeah, there are some lacunae in your presentation, what I feel. Your patient has undergone LASIK only in one eye?
Yes, sir. He told
only in one eye.
specifically that he undergone only in one eye 20 years back.
Okay, but somewhere in your presentation, I saw that word pseudoproptosis. That I think you mentioned only for the right eye. How did you make a diagnosis of pseudoproptosis? How did you make that?
Actually, on looking the rights, the
what
right
is pseudoproptosis? I think Madam asked in that previous presentation.
That is due to some that fullness in the periorbital region superiorly, sir.
No.
Actually,
Pseudoproptosis.
it was showing 21.
No, how do you make a definitive diagnosis of pseudoproptosis? See, sometimes the examiner will catch you. One glaring mistake you will be making in your presentation, they will catch you. They'll forget the other things.
Okay, sir.
You relax. See, how do you make a diagnosis of pseudoproptosis? Proptosis is forward globe is normal, forward protrusion of the globe with the patient looking straight ahead in the primary position of gaze.
Yes, sir.
Pseudoproptosis is either the orbit is shallow or the eyeball is larger.
Yes, sir.
So in your case, one of those two things might be there. From whatever presentation you have made, the facial symmetry, everything is normal. So it is not the pathology in the orbital bones. Now, to make a diagnosis of pseudoproptosis, probably it can be in the globe.
High
Okay.
myopia.
High myopia. So, did you measure the axial length of the eyeball on either side?
Yes, sir.
That you should have done. What is the measurement of axial length in the right eye and axial length in the left eye?
Right eye axial length, it was around 30.89, and left eye it was 31.
So almost similar, no? It is almost similar. Right eye, left eye is almost similar. Only the right eye you feel there is more proptosis. That is what you felt, pseudoproptosis. Right?
Yes.
That is what I think you mentioned in your presentation. That is one thing. Second thing is, LASIK, did you look for any LASIK mark on the cornea?
It was not visible, sir.
So patient, when did the patient undergo surgery? 15 years back.
Some 20
when was it done?
Years back, sir. 25 years back, sir.
15 to 20 years back.
Yes, 25 years back, sir.
25 years back. They would have done a PRK or a LASIK. It can be. Did you notice any corneal haze or anything?
No, sir. No corneal haze or no marks or.
No. What did you look for in the cornea when the patient tells you, "I have undergone LASIK"? Because earlier, for everything they will tell, "I have undergone LASIK." They would have undergone any corneal refractive procedure, they will tell you LASIK.
We can say mild stromal haze.
What did you look for in the cornea on slit lamp examination?
That will be thinning. And
thinning you cannot make out unless it is a very gross thinning. Did you look for any cut? A healed
no
scar?
cut, sir. That is no
healed scar. Did you see?
No, sir. That is
how
not.
do you make out? You can just take a small instrument, any instrument, blunt instrument or a cotton tipped applicator, instill paracaine, and just try to press on the cornea. Sometimes that scarring can be visible. That you should see. Okay. If it is a PRK, you will not be able to see at all. So one thing is, we don't know whether he has undergone surgery in both eyes or only one eye. And left eye, the vision is less because of what?
Because of the high myopia.
And probably with the posterior subcapsular cataract is.
Maybe cataract due to high myopia, or maybe
okay. Then you told there is some extraocular limitation also in this case.
Yes, sir.
I think in the right eye you mentioned. And on palpation, you told there was nothing. And in the history, you told there was some apparent orbital inflammation which subsided on medication.
Yes, sir.
What were you thinking of?
Sir?
What were you thinking of?
It may be due to previous dacroretinitis, or it may be due to any pseudotumor, some non-standing pseudotumor, lymphoma, unnoticed.
Did you try to see the lacrimal gland? Did you avert the lid and see? Did you pull the lid, upper eyelid laterally and see? Ask the patient to look down and try to see. Did you see any inflamed lacrimal gland?
No, sir.
Did you see any localized injection there? Or any, was there any tenderness there?
No, sir. No tenderness was there.
Okay. On movement, was there any pain?
Complaint of blurring vision and pain only. Photophobia.
Okay. Madam, you want to ask anything, madam?
Yeah. Hi, Vikram here. I think that was a case with a lot of, morbidities from the anterior to the posterior. And as sir rightly pointed out, I would first like you to revise your diagnosis. Would you like to revise your diagnosis or the way you're presenting your diagnosis? What's your primary pathology in the case with you? What is the primary morbidity in this particular case? Is it cataract? You put cataract as your leading diagnosis.
Actually, it's a
It's a case of
the right eye.
No, the uveitis is a presenting right now. Again, the uveitis is not the primary pathology in this patient. So that's something which all examinees will have to learn to categorize. What's your primary diagnosis? What is your secondary diagnosis? What is your tertiary diagnosis? Just because you've been told to present a case of uveitis doesn't mean he's not a patient of chronic anterior uveitis with secondary glaucoma or with steroid-induced cataract, isn't it? So this is the only episode the patient is having? This is the first episode?
Actually, he's telling a history that every 6 months once or past 5 years, he is having redness, at least yearly once.
He
but
does
there are
have
no signs of chronic.
Okay, absolutely. So you yourself said this is a globe which is 30 millimeters both eyes. So what's your primary diagnosis in this patient? Would you like to revise it? So it's a case of bilateral high myopia.
Yes, sir.
Yeah, this is a case of a bilateral axial myopia, or we do not know if it's a pathological myopia. So that's something which is staring at us. And again, when you have a case with paucity of clinical findings,
Yes.
here, right? You're not having too many findings, like there's no posterior synechiae, there's not a very flaring, but you had showed a corneal a fundus diagram which was staring at you. Would you like to? And what you just described was this is a tessellated fundus.
Grossly tessellated.
Yeah. So is that all? Would you like to say on that picture? So these are some things, you know, when you have not so many clinical findings to present, you should be able to elaborate on the findings which are already present here. So I would like you to revise your diagnosis, and what we are looking at is a case of bilateral axial myopia or a pathological myopia here with I'm sorry, I did not notice was it a posterior subcapsular cataract which you were having? Bilateral, or was it an immature senile cataract? How old was the patient?
He's 49 years.
It's 49 years. So would you put it as a senile cataract?
No,
I wouldn't like to be called senile when I'm 49 years old.
No, ma'am.
Of course, 45 is the cutoff in India. Then you say senile or pre-senile. So here it would not be pre-senile because it has associated, you know, findings in this eye. It is a high myopic eye, so it's probably not a senile. It's not a pre-senile. It's a definite. What type of cataract is there?
Maybe a complex.
Absolutely. You have a myopia associated out there. So you have a cataract with an associated morbidity over there. So that's again another fault in your diagnosis out here. Then you are also looking at a unoperated under refractive surgery.
Yes, ma'am.
Yes. So again, we don't have any telltale signs. If you have to believe that, you know, nothing, even if you had a PRK, you would probably be able to pull up something. But how would you be able to, suppose I said, I'll give you one test to go and find out whether this patient had corneal surgery, refractive surgery done earlier, what would you like to do? What test would help you to decide whether this person, let's say you're in a peripheral center, we do not have access, pardon?
Topography.
Corneal topography, yes, if you have access to it, but if you're in a peripheral center, on your slit lamp examination, you have not been able to pick up anything. So what simple examination, even in any centers doing cataract, will be able to tell you that? Yes? Absolutely. You just do a simple keratometry here and you would find a flat cornea there. If the cornea has been operated upon by anything, a surface ablation or a flap procedure, then you would find that the keratometry you would have difficulty in eliciting a good keratometry in these patients here. So that will again help you to go back and revise your diagnosis. If it was an operator, if you have a keratometry of say 44, 45, you know that probably a refractive surgery was not done for this patient here. But the patient is still using a -12 glasses here, right? And so did you in your history go back and ask, was he able to see at any point of time following his refractive surgery without his glasses? So that's something which I would have liked to cross-check, because we don't have records here in Indian patients here. We are not able to rely on the history. So the way we examine is how we would like to corroborate the history of what the patient is saying here. So then if you find that if he has a -12 and you found the keratometry is flat, how would you like to revise your diagnosis? He's having a regression. Right? The correction is not worked here, or they have probably done a partial correction, or he did not have any correction at all. So that's how you need to revise your diagnosis, and then you have an anterior uveitis in this particular patient here. Again, when you're describing hyperemia in an anterior uveitis, how would you like to describe it? It is circum. Right. Yeah. It's a circumciliary congestion. Yeah, it's a circumciliary. So these are very important features when you are describing a particular thing. So that's the take-home message I would like you to take, is that you should learn to categorize your diagnosis into a primary diagnosis, a secondary diagnosis, and a tertiary diagnosis. Sometimes you do receive tips in your exams that this is a case of a cataract. So you do not start presenting with, I am having a cataract, this. So that's how you should learn to place the importance on your diagnosis, by categorizing it into a primary, secondary, and a tertiary diagnosis. And when you have obvious findings like an axial myopia staring at you, what all would you like to describe in that fundus picture? Would you like to be more elaborate in describing? Was the disc normal? Were the vessels normal?
Actually,
Yes. Was the peripapillary region normal?
no, ma'am.
Is there something you would like to tell us on that? Was there an associated posterior staphyloма? To me, it looked like. Yeah, so these are some things, I would like to see. Whether the disc look large, the disc look pale. Were you able to comment on the cup disc ratio? How did the vessels look? Where was it a tilted disc? Did you have peripapillary atrophy here? Was there extensive chorioretinal degeneration involving the peripapillary region and the macula? So these are all findings which are all pertinent to the axial myopia or the pathological myopia which you're seeing. So as sir rightly pointed out earlier, we are not looking at sophisticated things, but we want you to present the basic things in your examination so that we can take you forward in your discussion and diagnosis. So I think taking this forward to just what is the differentials of uveitis. Uveitis is pretty simple in the way that you're going to look at, what are the telltale signs of prior uveitis? What are the signs in a current anterior uveitis? How would you differentiate old KPs from fresh KPs? So, and the types of KPs. So these are all some things which you all would be proficient with, but then you should learn to tailor and present whatever case you have in a proper manner, and do not miss the importance of any particular finding which you are seeing out here. I think in the interest of time, do we continue, or do we take the next case, or do we continue on this, Gopal? Anything else, Dr. Nagaraju, you still want to add on?
That's all, madam. That's all, madam.
Can go on to
Uveitis,
the
we
next
keep
case,
it as a
yes.
short case here in our.
Yes, yeah. Uveitis usually is a short case, and I do agree it is a little more complex, sophisticated in terms of taking it into discussions, looking at anterior uveitis, posterior uveitis, the telltale signs of posterior uveitis as well. So might be a little difficult for a postgraduate to take it into an advanced level, but do not miss on what you all have done. But again, very well done, Vikram, and thanks for that particular case, which was really enlightening. Yeah.
Actually, since we had only the long cases and no short cases in this
Yes,
particular
yes. So I
presentation,
think
we
it's
wanted
fine.
to cover everything 360
Yes,
degrees.
that's a really good.
We'll go into the last case today. That is the retinal detachment. Okay.
You can join us as a co-examiner, sir. Internal examiner. Dr. Gopal.
Yeah, no problem, sir.
You can go ahead, Dr. Jalak. Is everyone hearing?
Yes, yes, please.
Yeah.
Is Jalak muted? Is she muted? Yes, I think so. She's muted.
Sir.
Please unmute. Yeah. Now you can. Now we can hear.
Yeah.
Good
Go
afternoon. I'll be presenting a case of a 44-year-old male patient who was an automobile workshop mechanic, and he's coming from Kundakal. His chief complaint was diminution of vision in left eye for a duration of 1 week. History of presenting illness: patient apparently had good vision in left eye till 1 week back. Then he suddenly noticed diminution of vision in the left eye. It was non-progressive in nature, not associated with floaters or flashes. There was no association of pain, redness, or photophobia. He did not have a recent history of trauma. There was no recent history of transient diminution of vision. In his past history, he gave a history of trauma to his left eye 15 years back, for which he underwent a surgery to remove an intraocular foreign body. He was on regular follow-up with the hospital since then. In 2016, he was operated for a cataract in the same eye. And in the same year, he also underwent a YAG capsulotomy for a posterior capsular opacification. He does not give a history of diabetes mellitus or hypertension or any other comorbidities. His family history
had nothing significant. His personal history: he has a mixed diet, regular bowel and bladder habits, sound sleep, and no addictions. Coming to his general physical examination, here is a middle-aged male patient, moderately built and nourished. He's conscious, cooperative, and well-oriented. His other systemic examinations were within normal limits. His vitals were also within normal limits. Coming to ocular examination, his head posture was normal. There was no facial asymmetry. It's orthophoric. Extraocular movements, ductions, versions, and vergence were full and normal in all directions. Coming to his visual acuity, unaided visual acuity of right eye was 6/6, left eye was 1/60. Objective diffraction showed a plus neutralization of the vertical meridian with a plus 1.5 diopters, and horizontal meridian was neutralized with a plus 1.75 diopters. And in left eye, both the meridians were neutralized with a plus 5.5 diopters, and the reflex was pale. Subjective refraction, nil class correction was 6/6 in right eye, and there was no improvement in left eye. Near vision was N6 in right eye with a plus 1 diopter. Left eye near vision was less than N36. His IOP was measured with Goldman applanation tonometer at 10:30 a.m., which showed 16 millimeters of mercury in right eye and 10 millimeters of mercury in the left eye. Gonioscopy showed open angles in all cone. Coming to ocular examination, proper. Right eye periorbital area was normal. Eyelids, margins, lashes, and duct orifices were normal. Conjunctiva and sclera was normal. Cornea was normal in size, shape, transparency, and sensation. Anterior chamber was deep with Van Herrick's grade 3 and coed. Right eye, iris color and pattern was normal. Pupil size was 3 millimeter, which was round and regular, and which was reactive to both direct and consensual light reflex. Lens was clear. Coming to left eye, periorbital area was normal. Lid was normal in margins, lashes, and duct orifices were normal. Conjunctiva and sclera was normal. Cornea was normal in size, shape, transparency, and sensation. Anterior chamber was deep with Van Herrick's grade 3 and it was quiet. Iris was normal in color and pattern. Pupil size was 3 mm. It was round and regular. It was reactive to both direct and consensual light reflex. Lens, he had a posterior chamber IOL with my PCO and a YAG capsulotomy opening. Coming to fundus examination of right eye, at 1 meter showed red glow. Distant direct ophthalmoscopy showed media clear. With 90-day slit lamp examination and indirect ophthalmoscopy, disc had an oval shape with normal size, color, and margins. Cup disc ratio was 0.3, a normal pink NRR. Vessels over the disc were normal, branching dichotomously with an AV ratio of 2:3. Background retina was normal, and macula showed a foveal reflex. Coming to fundus examination of left eye, at 1 meter, there was a dull glow. Distant eye did not show any media opacities. 90D and indirect ophthalmoscopy examination showed disc which was normal in size, shape, color, and margins. Cup disc ratio was 0.6 with a mild temporal pallor. Vessels over the disc were rising in the center of the disc with which was branching dichotomously, and the AV ratio was 2:3. Background retina showed some peripheral laser marks in the periphery, which was seen superotemporally and inferiorly. And there was a shallow elevation of retina in the superotemporal quadrant, which was extending between the superior and inferior arcades. And in clock hours, it was extending from 2 to 5 hours with some superficial folds involving macula. I could not make out any breaks, and foveal reflex was absent. This is the fundus picture of right eye. And this is the fundus picture of left eye, which shows a pale elevated retina in the superotemporal quadrant extending from 2 to 5 o'clock hours, involving macula. So this is the fundus diagram.
Explain on the fundus diagram. Please explain the fundus diagram. Yeah.
Fundus diagram of right eye shows this. This is a normal fundus diagram of right eye. Left eye shows a pale elevated retina, which is probably a retinal detachment, which is shown with the blue color. And these are the laser marks, which are depicted with a black color. extending from 2 to around 5 o'clock hours. Case summary. Here is a 44-year-old male patient with history of 1 week duration of diminution of vision in left eye, with history of vitreoretinal surgery for an intraocular foreign body removal, and on examination showed contact finger to improve to just 1/60 on left eye and pseudophakia with Yak capsulotomy opening and fundus showing shallow elevation of retina temporally involving macula and diffuse ERA patches in the periphery. This brings to the provisional diagnosis of right eye presbyopia and left eye pseudophakic retinal detachment involving macula and status post VR surgery and status post Yak capsulotomy.
Dr. Maya, excellent presentation. Can you share the left eye anterior segment pictures? I think it was there in the slide which you presented.
Yes.
It was not there in the slides presentation sent to us. Can you just enlarge it? Can't enlarge?
It can't enlarge it.
You can stop, you can minimize the presentation into a normal presentation from full screen and hold on to the edge of a, you can hold on to the edge of a presentation and and bring it back to full screen.
Okay. The second thing is the patient has undergone 3 procedures in the left eye now for the past 15 years.
Yes.
One is primary trauma.
Yes,
and I want you to elaborate on the trauma, what he sustained 15 years back. What was he doing?
He was an automobile workshop.
You told he was. Right now he's not doing that. So
he's doing, sir. But he's not doing.
Can you remember what happened 15 years back? How he sustained that injury?
Yeah, he was telling, sir. He was hammering something. He was repairing a vehicle. He was hammering. So while he was hammering, only he sustained the injury.
Okay. Did you try to get any of the records the patient had?
We got records only from 2016, like from when he was operated for cataract surgery.
No, probably 15 years back, he underwent an intraocular foreign body removal. And I think 4 years back, he underwent a cataract surgery. In the intervening 10 years, his vision was apparently normal. What does that indicate? Where do you think would have been the entry wound? Patient underwent an intraocular foreign body.
In the central.
No, probably it is not in the cornea. It is not in the limbus. Probably it is more posterior. Probably it would have been a scleral entry. One. Second thing is he must have undergone some surgery. He has undergone a vitrectomy and an intraocular foreign body removal. You try to see if there are any. See, when you mention the clinical findings, you should look around the limbus and did you see anything there?
Any scarring? No, sir.
You didn't notice any of those things?
No, sir.
Okay, next. 4 years back, he underwent a cataract surgery. What type of cataract surgery he has undergone? He has undergone a phacoemulsification, or whether he has undergone a small incision cataract surgery or see anything else? Did you look for scars? That you should mention. As a postgraduate student, there will be some scars.
No, sir. No superior scarring was there. So probably.
What scarring is there? What scarring is there? Corneal scar is there? He has undergone a phaco or what? Clear corneal? No, must be. You should be definite in your findings. That you should mention. Okay. And probably it was an uncomplicated cataract surgery where the lens is in the bag, or where is it? Where is the lens placed?
It is in the bag, sir. You can see the rexus margin can be seen, sir, in front of the lens.
Okay. So after that, the patient developed a PCO and he has developed a.
He underwent a
postcapsular opening has been done. So right now the patient has undergone a vitrectomy. It is a post-vitrectomized eye.
Yes, sir.
Second, patient has undergone a cataract surgery. Third, patient has undergone a capsule. These are the 3 factors which can lead into your retinal detachment. All the factors are okay. All these 3 things. So that is how a post-vitrectomy RD looks like. Why do you think this RD has occurred?
You can stop sharing. You can stop sharing.
You showed some laser marks there.
Yes, sir.
And why do you think the RD has occurred?
So it's probably because of development of a new regma somewhere in the periphery. Because I could not identify a regma on examination, it might be somewhere.
Did you try to search for the area? Did you try to search for probably a large scar or a hole there? Probably that was the probable site of the intraocular foreign body.
Somewhere there around the periphery, in the laser marked areas.
Near 2 targets, I think 2 clock covers you have shown the laser marks being placed actually in the fundus diagram, whatever you have depicted.
Yes, sir.
You see probably an area of dark pigmentation confluence there. Probably that would have been the site of entry of the intraocular foreign body. Probably those areas probably would have undergone some atrophic changes, or some of the laser marks would have shown atrophic changes, probably produced a retinal hole and produced this RD. Okay.
Yes.
So what type of RD is it? How do you classify
Regmatogenous.
So it is a
RD can be classified as a regmatogenous,
what
tractional RD, exudative RD.
It fits into?
Sir?
What type of RD do you think this will fit into?
This will fit into regmatogenous RD, sir.
Regmatogenous. Madam, please take over, madam. Basics I have covered. Dr. Gopal.
Yeah, I think Gopal can step in, or you said Dr. Thomas.
No, madam. I mean, many a times what happens is, as Nagaraj sir said before, some of the, not all ophthalmologists who come for exams are generalists. There will be some specialists like Dr. Vanti, who is specialist in cornea. So you will need to ask them.
Okay. So
they should know,
when
they will know my type of questions.
Yes.
But they will not know it.
Okay. When you examine a case of retinal detachments, what are the particular signs on slit lamp would you like to say a pathognomic of a retinal detachment?
If it's a regmatogenous retinal detachment, there can be release of pigments from the RP, which can be seen in the anterior vitreous phase or even in the anterior chamber.
Okay.
Then IOP will be low in the same eye. Comparing to the other eye, it will be minimum at least 5 mm less than the other eye.
So the globe will be hypotenuse. That will be your first finding, which you would probably be able to pick up in these cases. Then
in this case, there is a yaw capsulotomy opening, which is again a risk factor for development of an RD.
So you would look for other risk factors, which would be?
Should have led to the RD.
Yes, there would be associated, like you have a history of trauma in this patient. There's a history of surgery in patients. There would be a history of high myopia in these patients here. So you would have some sort of an associated risk factor, which is commonly present for development for a regmatogenous RD here. Any other signs on the anterior vitreous which you can put on the slit lamp and see?
Pigments in the anterior vitreous.
What is it called? What's the sign called?
Schaffer's sign.
Absolutely. So what is Schaffer's sign? What will you see in Schaffer's sign?
Pigment clumps in the anterior vitreous face.
Yeah, pigment clumps. Are these clumps usually? Yeah,
no,
so you will see pigments, or you will find a lot of cells in. Suppose you see a lot of cells in an eye which is pseudophakic. Is that pathognomic as Schaffer's sign in the anterior vitreous?
It's not pathognomonic of.
So in Schaffer's sign, when you see pigments or when you find fine cells which are present in the anterior vitreous in eyes which have not been previously operated, then it be pathognomic of a retinal detachment here. But when you do see eyes which have undergone surgery earlier, then these will not constitute a Schaffer's sign, which could be because of the intervention which you have done as well, not because of a fresh RD which has occurred here. Okay, so what's the Linkoff's rule? You like to elaborate the Linkoff's rule? Yes.
Linkoff rule is used to identify a primary break in case of an regmatogenous RD. So if you see a RD, inferior RD with equal level of RD, probably the break is at 6 o'clock position. And if you see a inferior RD with one end elevated, the break is probably at the elevated end of the RD. And if you see a superior RD which is not crossed 12 o'clock position, you should look for the tear in somewhere 1 to 2 o'clock hours towards the inferior side. And if there is a RD which is a superior RD which is crossing 12 o'clock, the break is probably in the same side of the that is superiorly around 1 to 2 o'clock hours on the same side.
So it's a rule which helps you to localize the
primary break.
The primary break, so that it will help you to plan your management in your particular cases. When you find retinal detachment, what kind of degenerations predispose to retinal detachments?
There are some degenerations like lattice degenerations, snail track degenerations, cystic retinal tub, then white with or without pressure. All these are
Does
some.
that predispose? So then let me rephrase my question. What are the retinal degenerations which do not predispose to retinal detachments? So suppose I'm seeing there is a high myope, and then you are doing indirect ophthalmoscopy to look for the peripheral screen, the peripheral retina. In one, I am seeing a white without pressure. In the second, I'm seeing a paving stone degeneration. Which one will I advise for further intervention?
Paving stone.
Paving stone?
Yes, ma'am.
Not Leah's? Okay, I think you need to revise on the type of retinal degenerations which need interventions, and those retinal degenerations which don't. This is a very common question because high myopes, indirect ophthalmoscopy is something which all of us will be doing, and we need to talk to our patients and tell them which needs to be intervened and which does not need to be intervened here. So what would you find? What would you do when you find a high myope with a peripheral retinal degeneration, say a lattice degeneration which needs to be intervened? What will you look for in these, and what will you advise and do in these?
You look for holes in the lattice degenerations.
Okay.
There are holes, and especially high myope, we can take for laser so that prophylactically you can prevent an.
What do you call that treatment?
Barrage laser.
We call it a barrage laser. Would you like to talk about it? Okay, so let's just go on to a management. How would you decide what would you do for a retinal detachment?
Depends on what type of retinal detachment.
The basic principles, that should be enough here.
Okay. First, you diagnose decide what type of retinal detachment it is. You have to see the regmatogenous or a tractional RD or a combined RD. So once this is probably a regmatogenous RD. So for regmatogenous RD, surgeries are you buckling and vitrectomy with silicone oil or gas tamponade. So buckling. So either of these two surgeries you can proceed with. In this case, when you start with surgery, vitrectomy, if I'm talking about vitrectomy, ma'am, vitrectomy can be, this is already a vitrectomized eye. So in this case, you look for any incomplete vitrectomy. If it was in an incomplete vitrectomy, you stain with a triamcinolone or something, or another, or to see if there is any leftover vitreous. You complete the vitrectomy. Then you drain the subretinal fluid. Then you can laser the suspected area and fill in with a tamponating agent like a silicone oil or expansile gases. Now.
Okay. When is encirclage indicated?
There is a large tear involving more than 2 quadrants of the retina. Okay. And a large horseshoe tear. Then giant retinal tears. And there are tears in multiple quadrants.
Okay. What is pathological myopia? When would you call it pathological myopia, and how do you differentiate it from a routine axial myopia?
Myopia of more than 6 diopter should be there, but and axial length is
greater than
is more than 30 millimeters, no?
30?
28.
20?
28.
28? 26, I guess. Then what will be your fundus changes in pathological myopia?
There'll be peripapillary atrophy, temporal crescent, then gross tessellations, angioid streaks.
Okay. What is one refractive surgery? What are the recommended refractive surgeries for high myopes? Or what are the refractive
LASIK.
surgery procedures which can be done in high myopes?
LASIK.
High myopes. High myopes. So by high myopes, you already said it's over 6 diopters. So let's say in pathological myopes, you normally would see -12, -14, -18.
Phakic IO.
Phakic IOLs. Then there is a danger of performing one refractive surgery. Something to do with the lens.
What is RLE?
How can I handle the lens in a case of high myope? Say I am seeing a 45-year-old patient with mild posterior subcapsular cataract, high myopes, axial length is 28 millimeters. He does not want to wear his glasses any longer. What would you do for him? What's refractive lens exchange? Okay, so refractive lens exchange is a procedure where you do cataract surgery in a case of, or you would even do a clear lens exchange. But what is the recommended age for doing a clear lens exchange or a refractive lens exchange in a case of high myope, and what is the danger associated with it?
More than 18 years now.
Yeah. Why do we not perform refractive lens exchanges very widely? What is the danger associated with it? You would not have seen it very commonly being done. It is being done, but not very commonly. We do it only when there are particular indications. What are those indications, and why is it not be commonly done? It's commonly advised only after 45 years of age, so that you would not want to do it for young myopes. Because the danger, the association or the risk for retinal detachment is going to be very high if you do a refractive lens exchange in patients younger than 45. It still remains in patients we are doing above 45 years of age. So you would not, but that's another refractive procedure. So you can do ICLs, you can do refractive lens exchange, and bioptics procedures for these patients are some of the common refractive procedures in high myopes. I think Gopal, I'll stop here. Yes.
Who is the father of modern retinal?
I think there is nothing much. Yeah, sir.
Who is the father of modern retinal surgery? Doctor? Forgot your name. Maya.
Jules gone in.
Don't disappear. Answer the question.
Yeah. Jules gone in, sir.
No.
He started early surgeries.
Charles Keepens. Actually, he has given a statement for egmatogenous management. No, see the hole, seek the hole, and seal the hole. That is what he has told. And one of my professors used to tell, retinal detachment management is very simple. Simple to tell, I mean. Okay. So, mountain and Muhammad story you should know. Either bring the Muhammad to mountain or mountain to Muhammad. So, your mountain is your sclera. Your Muhammad is your retina. The detached retina. What are the procedures which will bring the mountain to Muhammad? All the external procedures, your scleral buckles and other. Next is bringing
put something
Muhammad
from
to
inside,
mountain to Muhammad. That is your internal tamponade. Two things. One is silicon oil, second is gases. You should know everything about those gases. Okay, thank you. Sir, all your students have presented very well. I think they can give the examination now itself.
That's a very encouraging statement, sir.
I think I would see. I don't want to add anything in this further. In this case, they have wonderfully discussed that case out. But maybe one point is you have talked about a vitrectomy surgery about 15 years back with a retained intraocular foreign body removal, and then a cataract surgery. I think you need to find some scars on the cornea, on the conjunctiva, on the subconjunctival area. You need to find out. It may not be there on torchlight, but you have to search. As sir said, you need to seek it out. Yeah. Definitely, like if a foreign body has been taken, and then there is a thick PCO, which means that it is not taken out through the anterior route, it is taken out through the scleral route. You will have a scar there under the conjunctiva. There will be a small blackish coloration. You need to search for that. Number two is, this tear is going to be somewhere in the temporal, between 2 to 5 o'clock, because that is the area of the, so you need to indent and see. Probably, did you do an indentation in direct ophthalmoscopy? This is an indication, because you have not found the tear. Again, just like sir said, you need to find the hole. If you cannot find the hole, you will search again and again. and take a break, search again to find the hole, indent. Okay, so that is what we have to do. Then third thing is this would be preferable to be treated with buckle, but there is a small hitch. This has been a vitrectomized eye, and the vitrectomized eye behave a little different from the non-vitrectomized eyes. So so it's about the surgeon's preference. Okay, so I think Dr. Vanity wanted to leave, but before leaving, I wanted Vanity madam as well as Nagaraju sir to basically comment on, how they should prepare, for the 3 years, how they can prepare for the last 6 months, those sort of things, some tips for postgraduates, citing your own experiences also. Maybe 5 minutes each, can you
start
please?
from day one, I feel. Day one, they should start preparing. It is not that they should just prepare on the eve of the examination. They'll come to you and ask them to relieve you to study and all those things. See, patients are open books actually. From every patient, you have to keep on learning. First important thing is, in the first 6 months, you should try to acquire all the basic clinical skills of examining a patient using different instrumentation that you should be very well versed with. Then you should try to present the cases as frequently as possible. And most importantly, whenever you present a case, you make a different type of presentation. And whenever you document a case, you'll make a different type of presentation. It should not be like that. So every case, whatever you document, it should be perfect. It's in the sense, it is not that it is just a case sheet. Yesterday there is a finding and today the finding is not much. You should not just briefly write the findings there. Every day you have to write the exact clinical findings on your case notes. And that is how you learn how to document whatever you see on the patient, how to put it on paper. From day one, this has to start. For that, you should acquire the proper clinical skills. And you should always carry a small book with you. And whatever cases you have seen, you just note it down. And you can discuss with your immediate seniors. Supposing if you find that you are not able to make out some findings, you call the patient after a couple of days, you read up and you just examine the patient once again. That learning is a continuous process. It has to come within. And the present generation, they feel just by having a iPhone 12 with a 5G connection, they will have all the knowledge in their pocket. They are having all the, see, I was just seeing this when we got accustomed to these computers only past 1.5 decades back. This Kansky on a pen drive, it is just about a few MBs, I think, 300 or 400 MBs. And our brain has got a capacity which is more than that. Probably a small amount of space in your brain for your Kansky and Parsons, you can almost easily walk through any examination. So for that, every day you have to read. You read the same book again and again. The basic clinical books, you can read Parsons, you can read Kansky, and you can read Payman. The latest edition of Payman is very good. All those books you should keep reading every day. Whatever case you have seen, you have to keep on brushing up, and you should try to ask your faculty also if there is any doubts. And that is how you have to acquire these skills, because acquiring the clinical skills and documenting this and just telling that doesn't just occur on the eve of the examination. It is an evolved process which you should start from day one. That is what I personally feel. That is one thing. Second thing is, there are certain books which I think you should carry in your pocket. One is that Clinical Methods, which is from Shankar Netralaya publication. That is a wonderful book. I always tell my postgraduates, I think it is in the 2nd edition right now, that you carry it in your pocket. It is a very handy book. That every case you see, you just open up and see, you examine the case, whatever points are not you have missed in your examination, you can just ask there. You just open the book in front of the patient only and ask. It doesn't matter. Or else you keep the book in the next room. You read there and come and ask the patient. That is how you should be. And another book is by Venkatesh Prajna. That is also a very good book. That very good book, which I think every postgraduate should carry every day with them in their apron pockets. And they should always carry in their purse a color color pencils and a bangle or something to make a circle, and scale, everything. See, whenever you get a ptosis case, they'll start running around. When you give a ptosis case to them, the PG will not be there. You would have gone to the provision stores outside to buy a scale, transparent scale. Everything should be there. And you should carry all the armamentarium with you. And you should carry a stethoscope with you. You should carry a tuning fork with you. You should carry even an e-hammer with you. All those things are very much essential. And that should start from day one. If you do that every day, I think there will be no issue in presenting in the examination. Probably the presentation will be the same, the examiners will be different. That's all. All the best to all of you.
Thank you very much, sir. Thank you very much, sir. Madam?
Yeah. I think that was a wonderful elucidation, Dr. Nagaraj, and I do agree with him. There is no replacement for hard work, for practice, and perfection. These are the three landmarks here. And I commonly tell my residents, because we do get residents every 6 months with us, so they are residents in different phases. And as sir rightly pointed out, you should know which phase you are in. So when you enter ophthalmology, for most of them it was the same for me as well. We do not concentrate a lot of ophthalmology during our undergraduation here. So it usually is a difficult subject and takes a particular time before you like to learn the subject and to love the subject. So it's about 3 months. So you should learn to familiarize yourself with the different aspects, with the different terminologies. Carry a small pocketbook, and every day in your first 6 months, whenever you see new things, new terms, write it down and take about half an hour in the evening to go back and read about it. And any book you like to follow, there are multiple books of ophthalmology, whichever is to your liking and to your frequency and suitability. Choose that book, start reading it, and add on those points which you think would like to simplify, categorize, or is missing in the book, and put it on as stick-on notes in those books, so that will help you to revise in your final month before you go in for your exam. So that's a continuous exercise which you need to keep doing throughout the 2 or 3 years of your residency for undergrad, for your post-graduation, and that will really help you to sort of put in together all that you are learning during the course. There's no replacement for practice and clinical experience. Every case you see is your Bible, and your patients are your encyclopedia. So the more you see, the more you learn. So always don't feel that, I'm having a lot of work to do. This is something which I find my residents or the present generation complains about. Always remember, the more you see, the more you learn. Each case still has something to teach me, even to this day. And I still think I've still not even touched 50% of what I have to learn in ophthalmology. And that's what patients teach you. And that's each case behaves differently, is in a different frequency, is in a different pattern, is in a different severity of presentation. And you learn from each of them every day. So always learn, and always think, whenever you come across any patient, what is the take-home message I can take from this particular patient today here? And I tell my residents this. The 3 years is our residency post-graduation here. It's just about 1,000 odd days in your life where you will really be studying for maximum period of time. And do not waste this time on all the other distractions of the worldly ways. You will have enough of time to concentrate on all those worldly things. Stress is something which always is present, and learn to cope with it. Cope with it with loving your work, and it will never be stress. That's something which I always tell my residents. And you should see, I'm one who joined residency when I was married. I went through my pregnancy during my residency. I had my daughter during my first 3 months, and my daughter is as old as my years in ophthalmology today. But I would encourage all of you who are out there, do not put your family reasons as an excuse for not studying. Do not put your family or your children. Make your family and children your strong points, and do not make them an exercise for performing fairly in your post-graduation. That's something which I do find some of the women falling back upon, and please do not do that here. And as sir pointed out, in your first 6 months, categorize yourself, look at all the terminologies, read up all the newer procedures, learn to handle all your equipments, and do all your tests, your applanations, your gonioscopies, your slit lamp examinations, your indirects, your 90Ds, whatever you have, you perfect in your first 6 months. Do 1 refraction every day. Read up your retinoscopies, read up your refraction, so that by 6 months, you're proficient with all the tests in ophthalmology which you need to know. And simultaneously read up all investigations which you're coming across your case. So that's in your first 6 months. In the second 6 months, you pick up all your clinical signs. You will not miss anything, and you will learn to make your diagnosis. So your first year is over. In your second year, you build up on looking at how you advise a patient, meaning how you will manage, what are the investigations you will do, and how you would go about the surgical procedures and the surgeries involved. And as you go along, you're of course learning your cataract surgeries, and you're learning the difficulties in cataract surgeries, and you're learning how to manage your problems in cataract surgery. So when your second year is over, in your third year, you will not miss anything, and you will talk about differentials of every particular case, and you will practice presenting orally. Remember, the more you speak, the more you present, the more proficient, and it comes subconsciously in a situation of tension, as you would be during your exams. So you need to practice for that throughout your course of period, and interact. You can have small discussion groups, and each of you can discuss and interact and share your experience of in a week or every day or as frequently as you think is important. So these group discussions also help to enhance your knowledge and your interactions based on clinical presentations, on clinical science, different types of cases you see, and then you do not get scared that this is a case which is very scaring, I probably will not do well. So these are simple practical tips, and nothing like learning and reading. It's always not looking at, like a reference book. Ophthalmology books are not reference books. You should know that if you're particularly seeing an RD, you know how an RD is going to behave. So if you learn to understand the natural course of any particular pathology, then you would probably think and answer from your knowledge on that pathology rather than just looking at references and answering from them. So I think these are some of the basic tips which I would like to share with my postgraduates. Would welcome any of them if they want to ask or want to approach us at any point of time. We'll be happy to help you. Thank you so much, Dr. Sai Kumar and Dr. Gopal, for this wonderful opportunity. And I do congratulate all these 7 brave students out here. I think we did not have a virtual platform the days when we sat for our exams, but I perhaps would not have been this brave enough to sit in front of a crowd of learned professors and present so bravely, so beautifully. I really congratulate and appreciate all the efforts which you have taken. Thank you so much, and this has been a wonderful learning academic exercise.
Thank you very much, madam. We are looking at somewhere around 934 playbacks, which means that in about a week's time, some 1,500 people will see this. So that's the statistics for you. And thank you very much, both of you. So over to Dr. Sai Kumar for some, World Glaucoma Day program.
Thank you, Gopal. And once again, thanks to all the examiners, the mentors, and the students who have done so well. As Madam said, I think, speaking to a crowd, thinking that you're being watched by a few hundred people, it's not a very pleasant experience for any student. And you have been really brave enough and, kept the flag of Cochin Ophthalmic Club flying high. And just coming to the Glaucoma Week, from today for 7 days, the World Glaucoma Week is being celebrated. And as usual, a Cochin Ophthalmic Club, we have devised some unique programs. Normally, we have some physical programs, we have some meetings. So this year, we are not able to do all that. We have 14 radio talks, 2 on each day. So 14 different ophthalmologists will be speaking on Cochin FM. 14 radio talks. We also have 14 YouTube videos, again on short, glaucoma videos, which will be released every day. 2 every day will be released. And to top it up, we have a beautiful poem on glaucoma in Malayalam by Dr. Surabha, who is a very, very accomplished literary person in our Cochin Ophthalmic Club. So that is what we are doing regarding public education during this Glaucoma Week. And we also have a small presentation on medical management of glaucoma, basically designed for the postgraduates. And that will be delivered by Dr. Thomas Arun Varghese, who is a very senior glaucoma specialist in Cochin. And I also, like I mentioned in the initial opening remarks, I thank Allergan for having associated themselves with this postgraduate program. I think Bala from Allergan is there in this Zoom group. So without wasting any more time, I request Dr. Thomas Arun Varghese to deliver his speech on medical management of glaucoma.
Thank you, Dr. Sai. And thanks to all the PGs and the Vanity Madam and Nagaraj sir for the excellent advice and words of wisdom really which you have given to us. Am I audible, Sai?
Yes, yes, you are. You are.
So mine is not a textbook talk because I'm textbook talk you can obviously get from the textbook. What I'd like to do is to also share a few practical aspects which I've learned over the years. So my topic is medical management of glaucoma. So obviously most of our management depends on the intraocular pressure because that's the main modifiable risk factor. So IOP technique itself is very important. And then I'd like to talk a little bit about anti-glaucoma medications, especially the new kids on the block, and then some non-medical aspects about glaucoma management. So importantly, of course, you get some pearls from the landmark studies that every millimeter of mercury is important in glaucoma control. And IOP lowering also reduces the conversion of ocular hypertension to glaucoma. The importance of CCT. At one time, I must admit, we considered it very important, but now we just remember that a particular patient has either a thick cornea or a thin cornea, and obviously keep that in mind when we manage the patient. CNGTN study also showed us that 30% IOP reduction slowed disease in some normal tension glaucoma patients. And of course, in normal tension glaucoma, you need to think of IOP independent factors. IOP in the low teens is beneficial in advanced glaucoma. And another individual risk factor is IOP fluctuation. So this is something which is very difficult to pick up, especially when we see the patient just for a few minutes in a day. So with diurnal variation of pressure and probably with new techniques of IOP monitoring, we'll be able to get a better idea about this. So just a few aspects about IOP measurement itself. Obviously, this may sound very basic, but you need to make sure that your patient is comfortably seated. It's a correct technique because all your decisions are going to be based on this. And of course, calibrate your tonometer and careful about disinfection. Home tonometry, this is what I was mentioning about the new techniques of tonometry. So probably in the future, you're going to have a patient measuring the IOP and sending you readings, and then you're going to make a decision of this. And again, new techniques like this, which gives almost just like your blood pressure, you have a Holter monitor, which gives a 24-hour BP recording. You're probably going to have techniques which are going to tell us as the important factors like IOP fluctuation and how important in a particular patient, the role of IOP fluctuation in the management of the patient. Anti-glaucoma medications are well aware of all these from all your textbooks. So mainly targeted at decreasing aqueous humor production or increasing aqueous humor drainage. So until now, we were mainly having agents focusing on the uveitis outflow. And now the new kids on the block are the Rho kinase inhibitors. There is, of course, role for aqueous humor reduction, and these are very effective medicines, especially beta blockers, except for the systemic side effects. Just a few points about brimonidine. It tends to work well, but a lot of patients do develop topical side effects to this. Carbonic inhibitors, they work, but they are not as effective as the PG analogs or the beta blockers. The cholinergic, the pilocarpine, we use obviously in certain cases, and now the new kids are the Rho kinase inhibitors. You can see the timeline of anti-glaucoma medication. You've probably seen this graph, this picture many times. So for a long time, there was just pilocarpine and timolol, and then we have the first carbonic anhydrase inhibitor, dorzolamide, then latanoprost and brimonidine, which really changed the scene, and then the new PGA analogs, and then now we have the combination of the beta-free combination of brimonidine and brinzolamide. The two pathways of aqueous drainage, we have the uveitis pathway, and all the postgraduate analogs are targeting that. And now we have the Rho kinase inhibitors, which is targeting the conventional outflow, the trabecular meshwork. So you have the two new kids on the block, the rifacimab, which is approved in Japan in 2014. And now we have the Indian preparations available, costing around 200, 250. It's twice a daily usage. And then we have the netarsudil, which is once a day, approved in US in 2017, costing rupees 400 to 450. So these have really given us more options in the management of glaucoma, And the important advantage is that a lot of these have been found to work even in patients who are using other medications. So even in patients, say on 2, 3 medications, these are still found to help to reduce a few more millimeters. And so they do have a role in additive treatment, and probably over time, they may become first line choice, but all that depends on the time and experience. And rho kinase inhibitors, they act by more than one mechanism. They also reduce the episcleral venous pressure, which is a new mechanism of action. Then we have other new medicines, the latanoprostene, approved by FDA in 2017, and this is a nitric oxide donating PGF2 alpha. We also have the new combination of two netarsudil with latanoprost. So both of these are targeting the drainage pathway. One is the UV scleral pathway, other is the conventional trabecular pathway. So this is another combination. It is not yet available in India, but has been approved elsewhere. The other options, mechanisms or methods of drug delivery people are always exploring. So this is the bimatoprost implant, you can see here, very much like your Ozurdex, so it's given as an injection into the anterior chamber. But one concern is the endothelial cell loss. So, and obviously they tried a higher concentration first, but then because of the endothelial cell loss, it is shifted to changed to a lower concentration. It was approved by FDA in March 2020. The other new kid on the block, the travoprost punctum plug, which is again being explored mainly in Singapore, and over time we'll see how the response is. The role of preservatives, you can see this is some of the preparations. Probably you may not have used this. So you had this brimonidine preparation, which is initially with preservative, BAK, and then they reduced the BAK concentration. And now we have preparations without BAK, where you have the Z, so zero BAK preparation. So most companies have realized the importance of preservatives and the damage they can cause, and they have shifted to the new brands have shifted to preservative-free preparations. This is just a patient I've seen in the last 1 or 2 months, and you can see he was on multiple anti-glaucoma preparation. You can see the severe topical allergy. So, and he was actually on a combination of bimatoprost with timolol and a carbonic anhydrase inhibitor. He was, and I was really, and the patient was quite insistent that it was the bimatoprost timolol combination causing this problem. So I said, usually this is another medicine. Usually, brimonidine causes this. And surprisingly, he did not have much follicles on the conjunctiva, like you see in brimonidine allergy. So this was mainly on the skin allergy. So because he was on multiple medications, you're really not sure which is causing it, or is it the preservative? So actually, I stopped all his topical medications, just kept him on oral Diamox for a few weeks till you can see that all the skin allergy is completely cleared, and then gradually introduced anti-glaucoma medication one by one. So sometimes you are really at a loss as which medication is the culprit, and sometimes you have to do particular approaches like this. And the logical approach, you can see, each patient is different. So you can see generally as the PGS have become more affordable now, most of the patients it's just once a day. It's very convenient. So most of the time, if patient can afford, PGS are the first choice. And then, of course, beta blockers, if affordability is the problem, if there are no systemic illnesses. Carbonic anhydrase do not give as much IUP reduction as I mentioned earlier. So probably only for mild to moderate reduction, you can use carbonic inhibitors. And second choice, if it's a good response with the first one, you can add another medication. But if the first response itself has been poor, then better to switch to a different medication. And with the new medications, obviously, we have more choice and you can juggle around, and different patients respond differently. Suppose sometimes you may have a patient who does not respond to one PG analog, but may respond to another one. So all these you need to find out with trial and error method. Non-medical aspect, something we really do not consider very much when you're in the hospital. The effect of daily routine, the effect on the compliance, effect on the medication, and what all activities the patient may be doing, which can affect this IOP fluctuation. So all these probably things we can pick up over time, and you can talk to the patient, and probably all these have an important bearing on their glaucoma control. So in conclusion, new IOP measuring methods may change our actual approach to glaucoma, especially giving a good idea about the diurnal variation, and try to achieve a safe IOP without disturbing the patient's activities. more options with newer medications, and keep in mind non-medical factors. As the movie in Patch Adams says, when you treat a disease, you win, you lose. You treat a person, I guarantee you, you'll win, no matter what the outcome. So remember, glaucoma is a chronic disease. It's not like your cataract patient. You see the patient operate, and then 6 weeks, 2 months down the line, you can discharge the patient. But glaucoma, you're going to see the patient again and again. So you need to talk to the patient, to have a good rapport with the patient, and so that both of you have a happy outcome. Thank you.
Thanks, Dr. Thomas Arun. Dr. Sai?
Yeah. Thank you so much. Yeah. So I think we come to the end of this day's program. It was a really wonderful Sunday. We have been holding Super Sundays practically every month from 2019 December, except 1 or 2 months. So I think this is the 14th or 15th edition. But probably this has been one of the most different and exciting ones, because this was not about didactic lectures. This was not about we speaking and them listening. It was we were listening to them, and it is a real good experience for all of us sitting here. So thanks once again. Anything you want to comment about the upcoming programs in this month, Gopal? Nothing. Yeah, we will.
I think we will have the first physical meeting this time.
Yeah, probably thinking of a physical meeting this month. Let's see how things work out.
Thanking Alargan once again. Bala, do you want to speak something?
Thank you, sir. Thank you very much for giving us the opportunity to conduct a meeting along with this Cochin Ophthalmic Club, sir. We're looking for more such kind of meetings in upcoming months, sir. Thank you, sir, for this.
Yeah. Thank you, Bala.
Thank you very much, Bala. Thank you, Arun.
Thank you. Excellent.
And thanks, everybody.
Yeah.
Thank you. Okay. I will just cut off the live.
I'm glad I was not having viva.